problem, predominantly seizures. They were not major deteriorations. They were patients that you would normally anticipate to worsen, for example, after a viral infection if they had a pre-existing seizure disorder type presentation, rather than a frank, neurometabolic neuroregression type syndrome.
That's brilliant. Thank you so much, Dr. Lim. I wonder if you have time, if you might look at the questions that are in the chat section and see if you can answer some for us. That would be very helpful. Thank you.
I will do. Yeah, thank you.
Thank you so much. So on to our last session before the break, which is Dr. Nick Wilkinson, who's a paediatric rheumatologist at Evelina, London.
Okay, just going to share. Can you hear me, Harriet?
We can hear you, yeah, and see you. And yep, your screen's come up.
Are we good?
Perfect. Thank you.
Okay, so it's a real pleasure to be invited to give a talk here, and following on the end of a fascinating show or afternoon of presentations. Now this one is probably going to cover a lot of what's happened before, or talked about before. And one of the things I'm really interested in is the use of the word hyperinflammation. It's now become common parlance. Before, it always used to be para-infectious, as Ming used before. And I was also delighted to hear that John used the word immunomodulation as opposed to immunosuppression. And I think some of these words describe how we're nuancing our understanding and our treatment of conditions such as in PIMS-TS. Now, PIMS-TS, as in adult COVID, is really an illustration of hyperinflammation, or just the networks of an interplay between cells and proteins of both the innate and the adaptive immune system, involving pathways that have cascades as well as redundancies, and none of it is really entirely predictable. And all of this is obviously to treat the invading microorganism, but at the same time having to avoid harm to self. Now, that's where rheumatologist comes in, because our principal concern is how do we adapt the immune system to avoid this harm to self. And we've been using immunotherapies really since immunotherapies began. Here I've just popped up a picture of rheumatic heart disease. And this is probably the first illustration of where we began to influence the impact of damage. Rheumatic heart disease was first characterized really in the 1880s. And then it wasn't really until 1940s that it was to be understood that it was secondary to a streptococcal infection. And the first treatment really with penicillin was around 1942. Shortly after that, Philip Hench at the Mayo Institute then isolated cortisone and used it pretty much soon after he had first used it in rheumatoid arthritis in 1948. And sort of in the early 1950s, there were lots of reports of the use of cortisone in acute rheumatic fever. But still, 70 years later, we still don't know of the true value of steroids in acute rheumatic fever. And that's salient. Now, what we're not really talking here is about rheumatic fever. It's about the acute scenario in PIMS-TS. And one of the models for this has been toxic shock, as well as the shock from myocarditis. And this is a schemata from the Weizmann Institute in Israel that compares the genetics and the molecular biology of different inflammatory syndromes to see where there is overlap. And that's what's shown here. But it's not just about toxic shock. What we've noticed is there are more incidences of macrophage activation syndrome. Now, that's the term I use in rheumatology, or secondary HLH, hemophagocytic lymphohistiocytosis, which I still struggle to say. Then there is the overlap with Kawasaki disease and the presentation then of coronary aneurysms, and also KD shock with its myocarditis. And then there's all the other infectious phenomena, such as with acute kidney injury and all that Ming described. And this all begins with a trigger, and then an inflammatory pathway that then seems to divert at some point that we don't understand yet, and is committed to different outcomes. And we have to determine where to intervene, how to intervene, and at what time point to intervene. As John described, the most important thing here is organ support along with antibiotics. And the treatments that he also raised were IVIG, which we commonly use for Kawasaki disease, steroids, which has been used for toxic shock, but is also commonly used in many other inflammatory conditions. And then the more recent use of biologics, which are complex proteins that are produced in a biological way as opposed to an industrial way, and hence its name. And these target very specific proteins in the immune pathway. But also, as John described, this isn't just about the immunotherapy, it's also about all the other aspects, and there's the change in the complement pathways. There is influence of potential of vitamins, and so the REMAP-CAP study, which was originally for community-acquired pneumonia, has been adapted to look at, it's a multinational study that's been adapted to look at the effects of COVID, and includes a vitamin C arm. Now, as I mentioned, that we're now using the word hyperinflammation, and we're using immunomodulation as opposed to immunosuppression. But when we first started, there was just this concern about using immunomodulatory therapies. And I want to bring us here to a case that was at the end of March, so about 3 to 4 weeks before those first cases presented that Shelley presented. And here we had a young lad of 8 with trisomy 21 who had had previous episodes of ARDS. And he presented initially with a fever and persistent cough, went home, came back, obtunded then a couple of days later, and his condition significantly deteriorated. He ended up having 3 cardiac arrests while on ITU. There was an intra-hospital transfer for consideration of ECMO, and he remained really quite unstable, pyrexial, with a very high mean airways pressure. Now, even before we began to treat with immunomodulation, his inflammatory markers were beginning to settle. But because we weren't having any impact on his general condition and his ventilatory needs, we then thought, well, what immunomodulation would we use? And the first one we reached for was anakinra. This we've used in macrophage activation syndrome, and it's considered safe. So it's been used in very high dose, originally in sepsis syndromes, and found not to result in a deleterious outcome. So it was thought that we could use that, but it didn't have much effect. Then IVIG, because again, used in toxic shock. So we felt that it would be safe again, and we ended up then using IV methylprednisolone. And here's a graph, and it was specifically looking at the outcome here. And the outcome was, how can we get this lad off the ventilator? And so you can see that the impact of anakinra and then of IVIG had no impact on the ventilator requirements, and that changed then with the methylprednisolone. Subsequent to that, as I said, 3 to 4 weeks later, I was also on at the weekend when we had these 5 that Shelley referred to who presented from the same area of London, what 4 of them were, with this form of presentation. And one had received IV methylprednisolone and the others hadn't received immunomodulation. But when we went to do the follow-up scan, as you would do, but these are in older children, I think this lad was 14, we found giant aneurysms. And at that point, it was decided, well, we have to give IVIG. The aneurysms have occurred, so it might be closing the stable door after the horse has bolted, but it was still thought to be worthwhile. And from the best available data at the time, we also gave infliximab. And this is because there was a great paper that looked at the incidence of coronary aneurysms, including giant aneurysms, and looked at, well, what was the impact on regression of these aneurysms afterwards. And infliximab was thought very much to have a beneficial effect. So that's why we used infliximab. But we still didn't know how and when to use these medications. And in fact, we still don't, as John has described. And so we need a structure, and that structure is provided by the recovery study. It was possible to recruit children really from the start, but the platform wasn't right for kids really until about October, when there was consideration for the treatment of PIMS TS. And we've been very much advocating the use of recovery so that we can begin to learn when and in whom these treatments are effective. John briefly mentioned, and here's about the randomization. So there are two-stage randomization and two parts of the first stage. We don't tend to use azithromycin, so you're able to opt out of randomizing to that. And so it becomes really whether to use standard of care for your organization compared to IVIG or methylprednisolone. The second randomization, or the second part of the first randomization, is to convalescent plasma, and I'm not aware of people who have recruited to that yet. And then the second stage intervention is with either standard of care or tocilizumab. Now, everyone recognizes there are some limitations to this, given the complexity of outcome of PIMS TS, but it's a successful study because it has an adaptive design. And I'm not going to go into that here, but the important things are, as all of previous presenters have said, is that we need to think about Kawasaki disease, this particularly in the younger age group. We need to think about sepsis and then secondary infection. We need to think about other outcomes, including neoplastic and neurological outcomes, and that's what's important. So I thought I'd just come back to, what is the point of treatment? Well, the point of treatment is specifically towards outcomes. And what are these outcomes? So we know that mortality is exceptionally low in this population. And so then it's, well, what is the morbidity from this? And we've had good presentations, or we'll have a further presentation about the cardiac impact after the break. And Ming has recounted all of the neurological outcomes. But in terms, for most patients sitting in secondary care, it's what we're trying to here is avoid intra-hospital transfer, and from any ward basis transfer then into PICU. We now have fantastic fora by which to discuss these patients, because the outcomes are not obvious, or the interventions are not obvious. And so discussion allows us to triangulate then towards what we think will be the best intervention. And then that's towards then having fewer PICU bed days, fewer days of ventilation included in that, shorter duration of hospital admission. And then the final thing that hasn't been mentioned is readmission. This is data from a summary paper, not quite a systematic review, in August, published in the Lancet, and shows here that coronary aneurysms occurred in around about 7.5% of the population, which you would say is probably in keeping with IVIG treated Kawasaki disease. So there is still a significant number of patients who are ending up with aneurysms. A very large proportion of the population have had significant cardiac dysfunction, and a lot have been treated in intensive care, which sort of describes, I think, the tertiary population that has been seen, and doesn't necessarily include all of the secondary care. What was also important is the age differential, and this was highlighted very much from the centers in New York, which showed that the Kawasaki disease type picture for PIMS was more in the 0 to 5 year group, whereas in the older group of 13 to 20, there were far fewer KD, but they're still occurring. And in this older group, there was much more in the way of myocarditis and cardiogenic shock. I've also taken the opportunity here to say, well, if we're thinking about Kawasaki disease, then should we be recruiting to a Kawasaki disease specific study? And this is just coming online, which is the KD-CAP being led at Great Ormond Street. And really is testing the benefit there of steroids together with IVIG compared to just IVIG alone. And it's important that we consider recruitment to this study as opposed to just recruitment to recovery. John has already covered a lot of the risk benefit of the individual therapies, and I'm just going to go over it again, taking here, well, what are we looking at in terms of outcomes? So IVIG has become a standard treatment, really because of Kawasaki disease, and we're trying to avoid the coronary aneurysm. So very specific and discrete outcome that has lifelong impact. But IVIG is also used in toxic shock, in macrophage activation syndrome and vasculitis, although the evidence in these conditions is still really to be fully evaluated. And the risks are not inconsiderable. And one of the principal risks, again, as John mentioned, is the fluid load, especially in someone with pump failure. There's also the risk of adding to the thrombotic risk, to kidney disease, to aseptic meningitis. So all of this impacts on the outcomes that we've talked about. And one other important aspect about IVIG is the cost, and that it costs about £2,000 per dose, which means that the access to it then is very poor in low income countries. And so we have to think of alternates, which would include steroids. Now, steroids have become a standard of care. Then its use in adult COVID disease is no longer debated, and it's standard care, but as the form of dexamethasone over 7 to 10 days. We tend to use methylprednisolone because that's what we're familiar with in pediatrics, and then that's our culture. It's also used commonly for macrophage activation syndrome. It's been used in toxic shock and as a standard therapy in autoimmunity. And the risks, as John has also described, are not inconsiderable. And one of those risks is the higher dose you use and the longer you use it for, there's a greater risk of secondary infection and potentially compromise to the treatment of original sepsis. It also has neurological compromise as well as raising the blood pressure and all the complications arising from that, which again feed into prolonged hospital stays and potentially readmissions. Tocilizumab has been used, so we originally started to use infliximab, but then to align with the recovery study, we moved to tocilizumab. And we still don't know its role, and we cannot at all confirm its role in PIMS TS, but what we have found is it's generally safe. The benefit in COVID is still in equipoise. The REMAP-CAP has stopped recruiting because they found it was beneficial to that arm of their study. But the recovery study identified that they hadn't been specific about the value that tocilizumab adds to treatment, and so has continued to recruit to that arm, as we do. In pediatric rheumatology, we're commonly use it in systemic onset juvenile arthritis as well as polyarticular juvenile arthritis with very good effect. And in adult rheumatology, they very much use it for cytokine release syndrome in CAR therapy. Very few side effects have been found with tocilizumab in the pediatric population, and certainly in our population of systemic onset JAA. Now, the experience of the adult team is obviously confounded by the duration of treatment to patients on adult ITU and their use of steroids. So we cannot disregard the impact of tocilizumab on secondary infection. And also it costs between £500 and £1,000. So it's not available to everyone. Here is an analysis by the recovery study to confirm why they want to continue randomizing, and shows that there's still yet to be established benefit comparing all the studies to date. The temptation to use a biologic therapy is because we record at times of inflammation very high levels of cytokine, but it's not a bucket that just fills up with a particular type of protein. This is a real complex, as I mentioned, interplay of all the cytokines with levels of redundancy across this. And so we looked at other therapies, including targeting IL-1 beta, TNF alpha, and now even with signal transduction, such as with the Janus kinase inhibitors, baricitinib, which seems to have some promise. Our standard of care, we've sort of gone over, is principally around, again, organ support, antibiotics, and then IVIG, IV methylprednisolone, and tocilizumab. And this is just quickly a description of those drugs that we've used, and we've used it in just over 50 patients, 34 cases of tocilizumab, 7 patients we've used anakinra, really for macrophage activation syndrome, and then right at the start with the concern about the aneurysms, we used infliximab. Overall, we found these drugs to have been safe and not seen significant infectious signals associated with them. And what we found is that of the first 70 patients, there were 9 readmissions, and only 1 of those had a biologic. So 8 had not received, of the readmissions, had not received a biologic. So whether there is a protective effect subsequently, tocilizumab, for instance, has a half-life of 13 days, and the drug will be out of the system after 5 half-lives. And as John also identified, is that over time, we have seen reduced in length of hospital stay. How much of this is down to our recognition and early treatment is unclear. How much of it's down to our confidence, but also how much is down to immunomodulation yet remains to be unpicked. One final thing before I finish is that we should still be considering other biologics. And one particular thing is patients who are already on a biologic at the time of getting COVID. And this is from a secure IBD database, where they've recruited across the world 4,500 patients, with 4% of all patients on this database having been admitted to ITU, having ventilated or death. And so it's a composite number. Of those in remission, there's a 4% of this ITU ventilation or death. But if you had been on TNF inhibitor at the time of getting COVID, then you only have a 2% risk of that, and included is a very low hospital admission rate. And so this cannot be ignored. It's also reflected in studies for rheumatoid arthritis. And one final thing is that because of the complexity of this, then maybe we should be looking towards risk stratification in a better way. And I'm sure that we will unpick this in the future. This is a risk stratification for HLH, which says whether you should intervene or not. So maybe we need a tool that allows us to know which drug to use, and maybe that will come with time. So just in summary, there is no single answer to the treatment of hyperinflammation. Organ support and antibiotics remain the primary approach. You've got to treat the patient in front of you, or consider their age, what are the difficulties they're running into, and what is the outcome that you're trying to achieve. So said in another way, there are variable outcomes for PIMS-TS with overlapping inflammatory pathways. The benefit of immunomodulation is yet to be shown. We need the structure of a pragmatic study such as recovery, and risk stratification may be what is needed for the future. Thank you.
Thank you so much, Nick. And I'm hoping that you're able to stay for the panel at the end, because I've seen lots and lots of questions coming in. If that's okay?
Sure.
Or in fact,
Yeah.
I mean, I wonder if it's worth, we have got a few, we were going to have a break, but we're wondering about whether just to carry straight on rather than a break, because I think if you do need loos and coffee and things like that, then hopefully you can fetch them. So, oh, sorry, I can hear one. I could hear some sound in the background. Oh, there we go. Okay, Nick, I'm just going to pick one at random, and I hope it's an interesting one. Okay, so in your readmitted patients, what was the time range after discharge that they were readmitted, and did they all present with hyperinflammation, and were the clinical features similar to the initial presentation?
So we haven't fully analysed all of the readmission data. It was everything from a few days to actually a week or two, even longer. And most of them actually didn't have hyperinflammation. So one could argue then it's a tenuous connection between the use of a biologic and readmission. But it might not be, because it might be then around the degree of damage that has been caused by hyperinflammation. So I think it's just a signal, just to be looked at, and there were lots of reasons for readmission.
Brilliant, thank you, Nick. Okay, so we are going to move into the sessions that we had planned to have after the break. We're just going to go straight in. I think it's the benefits of doing things online. I'm going to share my screen again, but I think Kate Plunkett-Reid is going to talk everybody through. So let me just make sure I can get that up on my screen. There we go. Hopefully you can all see that now, and I'll pass over to Kate.
Hi everyone, and thank you for staying with us. If you've been staying with us since the start, we understand it's a long session, but we're getting through it and hopefully all of it's really useful. So as we said, we're not going to have a break because we've been running slightly behind time, and we kind of factored that in, and we figure that most people using Zoom can go and grab a coffee at some point anyway. So we're about to head on to this afternoon, which is more of a cardiology focus. Before we hear from the physiotherapists, and then we're going to go into a panel session this afternoon, which includes lots of the fabulous speakers we've already had and a few others. So if you've not managed to get through any of your questions, please feel free to put some either on Slido or on the chat for the panel later on today. And obviously for any that we miss across the day, we will try to probably summarise some onto some kind of sheet when we share the recording as well, so that we can try and get everything answered. In terms of the Zoom account, for those of you that have missed it, it's been upgraded. So I can see there still are plenty of spaces now. So if you know anybody else that wants to join, they should be able to get on. And we'll continue to monitor that as the afternoon goes. So without any further hesitation, I'm going to pass over to Dr. Philip Kuchera, a consultant cardiologist at Great Ormond Street, who's going to talk through PIMS TS from a cardiologist's point of view.
Hello, thanks, Kate. Can you see me? It seems that my video is not working.
No, I can't see you, but I can hear you fine.
That's perfect. So I will just share my presentation then.
I can see you now.
Yeah.
Okay.
Can you see the presentation?
Perfect.
Perfect. Yeah, excellent. Thanks, Kate. So my name is Philip Kuchera. I'm one of the cardiology consultants at Great Ormond Street Hospital, and I am the cardiology lead responsible for the Kawasaki clinic. And so the data I will present will just basically focus on the data that from Gosh. I will not talk about other centers. So before I start, I would like to thank some of my colleagues for helping to collect all the data and then just doing the spreadsheets. So this is basically what we are currently seeing. So on the left side, you see the sort of patients being referred to our service with the Kawasaki phenotype in 2020 and the beginning of 2021. And you see very obvious two waves. So one is corresponding to the first COVID wave, and then there's an upstroke starting from sort of late September. And this is what we are basically seeing now. And then just to give you a flavor of what we saw in 2019, is basically the graph on the right. So you see a very steady increase in the number of patients we saw during that time. So I think there's no doubt that there is a certain time delay between the peak in the adult between the peak in the COVID in the adult population and the sort of beginning of the peak of our PIMS TS patients. So this is what we saw, and this is push data, what we saw during the first wave. And basically, after that, there is an increase. It started after this sort of increase, and then now gets more dramatic after this this peak. So the age distribution for the patients presenting now is way different from what we saw in 2019. So in 2019, we saw a typical Kawasaki age distribution with patients less than usually 3 years of age, whereas now it's more an older population with usually population of 9 to 10 years, but there is also an important part of patients with the sort of typical Kawasaki age range, less than, let's say, 3 years of age. So even if you split the current numbers in two different groups, less than 5 and more than 5, you still see these two peaks in sort of in the graph. So you can't really say that it is something that is happening only for the older patients. So I will now take you through various aspects of what we do with patients and what is happening with them from the cardiology perspective. So just to tell you, all patients, when they come to GOSH, they have a baseline scan, the PIMS patients, and then after discharge, we normally see them at 6 weeks. Whoever has cardiac dysfunction will have a sort of more detailed follow-up, but usually seen at 6 weeks. And then we also plan and follow up at 6 to 12 months. And whoever, after a best clinical guess, seems to have a sort of Kawasaki disease, then we would just follow the current guidelines. So I will start with cardiac function. So this is data from the first wave. So we had 12 patients with some degree of cardiac function dysfunction, ranging from basically unmeasurable to very minimally decreased. And what I would like you to see is basically that in all cases, the cardiac function normalized, and this was very rapid. So this was basically within up to a week. In most cases, cardiac function fully recovered. So this is something that is very interesting, and this is also what we see at the moment. So far, during the second wave, 43 patients out of them, 18 had some degree of cardiac dysfunction. So this is more than in the first wave. And ejection fraction range so far is 28 to 52%. And in 3 patients, and this was not the case in the first wave, the first scan was not the worst. There was sort of deterioration in the cardiac findings during the admission. And so far, all patients with with a follow-up scan discharged had normalization of their findings, which is very encouraging. And this is what we saw in the first wave. So this is how it looks. You see quite significant dysfunction of global dysfunction on this picture. And 6 days later, sorry, the pictures are not moving great, but complete normalization of the ejection fraction. So this phenomenon is very different from what we saw in the pre-COVID myocarditis cohort. So this is a very nice paper from 2014, which basically summarizes how realistic and how quickly we are we can expect improvements in cardiac function. And what we see is basically in the lucky patients, there may be an improvement in cardiac function, but it may take much longer. So we are talking about, let's say, a period of up to 3 years where we could expect some improvement. And also, I think it is very obvious that the patients with who present with PIMS, CS, and then some degree of cardiac dysfunction do have higher inflammatory activity compared to the rest of the cohort. This has been shown on our numbers from the first wave. So they had a higher CRP, higher ferritin, lower albumin, and also they not surprisingly had higher NT-proBNP levels, but also higher troponin levels. I think these two markers need to be judged with some caution, because we saw also unmeasurable BNPs in patients with strictly normal echocardiographic function, which means that this marker may also be very high in patients with sepsis in general, without this really meaning that this is due to decrease of cardiac function. And also troponin, I think many of patients being transferred to us with PIMS-CS, regardless what the status of their cardiac function is, may also have a raised troponin, and sometimes it may be over 1,000 nanograms per liter, and still they do have a normal cardiac function. So this graph is just to show that the inflammatory activity plays basically a key role in how well the cardiac function recovers. So these are the CRP levels when patients presented during the first wave with cardiac dysfunction. And as you see, this is the first normal scan. And basically all of these patients had their CRP in the range of, let's say, 50 to 70. So this is really when we can expect that things will go back to normal. And I think this only underlines the necessity of good sort of management of the inflammatory activity. And if this is well managed, then then we can expect for things to go back to normal. And I think this phenomenon of I would say myocardial stunning, where basically the myocardium has the ability to go back to normal, has been supported by other papers. So this is a paper, one of the few papers describing autopsy findings on patients who died because of COVID. This is from the adult literature, and these patients had no sort of fluid and myocarditic changes on their autopsies. So we are not talking about something that would be similar to the pre-COVID myocarditis. And also this has been seen in the case we had, the ECMO child we had here at Gosh, who had a cardiac biopsy, and again there were no sort of fluid changes suggestive of myocarditis. We did a couple of cardiac MRIs on patients from the first wave, on the sickest ones, and very reassuringly, and this was a few months after the initial presentation, and none of them had any problem on their sort of cardiac MRI, which again shows that basically everything goes back to normal, which is very reassuring. So now I will talk about cardiac valves. So what we see in some patients is a picture of panvalvulitis, which means that basically all the valves are affected. So it can be from very trivial to, let's say, moderate to severe regurgitation across any of the cardiac valves. And this is a quite busy slide, but I think it summarizes quite nicely what happened during the first wave. So basically, this would be the mitral valve, this would be the tricuspid, this is the aortic, and this would be the pulmonary valve. And the darker is the shade of the red color, the more significant was the regurgitation in each patient. So each line represents one patient, basically. So you see this column would be the initial presentation, and this would be the follow-up, that many patients presented with mitral regurgitation, tricuspid regurgitation beyond the sort of trivial physiological leak. And some patients with aortic regurgitation and pulmonary regurgitation as well. And you see there's quite dramatic improvement in these findings in the whole cohort. So we use tricuspid regurgitation also to measure pulmonary artery pressures. And reassuringly, there was no one with high tricuspid regurgitation velocity. So basically no one that would have pulmonary hypertension from the whole cohort of patients in the first wave. So now we'll talk about coronary arteries. So this is a topic that has been quite extensively discussed in the last few months. So this is just to show you what are the clinical presentations in our patients in the first cohort. So RUSH 6, so these are the Kawasaki, so the 5 classical Kawasaki signs. RUSH 69%, conjunctivitis 66, oral changes 54, and peripheral edema in 41. Unfortunately, lymphadenopathy was not always well documented, so I just left it blank. And as you know, we stratify the risk in patients with Kawasaki disease using Z-score. So if there's no involvement, it means Z-score is less than 2. Dilatation only would be 2 to 2.5. Dilatation only means that this could be a very non-specific sign in patients with sepsis in general, for example. So this is something we see quite often also in patients with other sort of systemic conditions. And then small aneurysms, 2.5 to 5, medium 5 to 10, and large would be more than 10 or more than 8 millimeters in absolute dimensions. So I would like to stress a few technical limitations that may explain why in some patient papers there is a very high incidence of coronary artery sort of changes reported. And then in some other papers that the incidence is fairly low. I think it is very important to define a few things before we really talk about sort of evaluation of the coronary artery. So basically Z-score is something, is how many standard deviations we are from the mean. So if it is equal to 0, it means that that the value is equal to mean. If it is 1, then it means that we are 1 standard deviation from the mean. So statistically, just purely statistically, it means that within the population range, there will be 0.6% of our patients that will be healthy and will still have a Z-score of one of their coronary arteries more than 2.5. And the same will be for a higher Z-score, so let's say 3, for example, would be in 0.1% of the population. So this needs to be taken into consideration. And also we have either a right or left dominant coronary artery system. And this means that if the right is dominant, then we would expect the right coronary artery to be slightly bigger than the left. And again, this may have influence on the measurements. So there's a number of scoring systems. So this is just to show some of the currently sort of used systems that you can easily access on the internet. And just to give you an example, this is a hypothetical child that would be 9 months, 8.5 kilograms, 70 centimeters. And then I just use deliberately these numbers so that in the Boston Z-scoring system, all the Z-scores are just below 2. So this would be regarded as a normal, basically. These would be normal measurements. And you can see that moving across the different sort of systems, you see that for the left anterior descending coronary artery, there would be 3.3, for example, for Lopez, which would already qualify for small aneurysms and possible treatment with low-dose aspirin. So there's quite a lot of variation for exactly the same numbers across the data sets we use. So this is also something we have to bear in mind. And then one last thing is that the shape of the coronary artery is conical. So basically the mouth is larger than the segment that is, let's say, a few millimeters away from the ostium of the coronary artery. So we should avoid ideally this region and start measuring ideally only from there. So the current recommendation is 3 to 5 millimeters distal from the origin of the coronary artery, and also we should ideally avoid bifurcations. So as you see in some papers, the methodology is not well defined, and they basically advise to measure in the ostium, which my feeling is that this is methodologically not correct. So one last comment on what is called perivascular echo brightness. So often when you do a scan, you see that the coronary artery is normally looking, but is echo bright. And some people may believe that this is a marker of inflammation, that there's something going on with the coronary artery. But this has been criticized in a number of papers because it's a very subjective sort of parameter that depends on the setting of your ultrasound. So this is not currently recommended for clinical use and should just not be used in management of the patients presenting to us with a Kawasaki picture. And also we should not forget that there are other conditions that may lead to dilatation of the coronary arteries. So many of our patients are from ethnic minorities, and it is important to bear in mind that some of them may have sickle cell disease, and patients with sickle cell disease may have coronary artery dilatation without this being really relevant to what is happening now. So these are the patients that we had during the first wave of COVID, and then partly at the beginning of the second wave. And unfortunately, today I saw 2 other patients with very significant coronary artery aneurysms. So that I would add, I didn't have, unfortunately, the time to add 2 other patients, but you see there's quite a wide range of values. But what is important is out of this cohort, if we take the patients with, let's say a minimal dilatation, like this one, for example, where it goes up to 2.4 or 2.5, which is quite non-specific and likely just to resolve without any sort of further sequelae, then and then if we take the patients with sickle cell disease out, then I would have only 2 patients with significant respiratory or neurologic symptomatology, which is something we would not really expect to see in Kawasaki disease with, and I think this is very important to stress, with progressive coronary artery dilatation. So out of this cohort, I would have only 2 patients that would have this type of problem. And then lastly, I will briefly mention something about the ECG. So in total, we did not really see any significant arrhythmia in the whole cohort of patients from the beginning of the first wave. So we had 3 patients with first degree AV block and 3 patients with junction rhythm. in a few cases, we saw significant QTc interval prolongation, which was likely to be pharmacological in 2 cases, and in 2 cases it was even extreme. And again, all this normalized during the follow-up period. I'm talking now about the first wave patients only. So these are the typical changes you may encounter. So this is a admission scan. You see very sort of non-specific repolarization changes with a normal QTc interval of 422, but then 6 days later, same patient, you see that the QTc interval is prolonged up to 516. And then when you see the patient later on during the follow-up in clinic, you see that the T waves are way different from the admission ECG. They become peaked. So these changes, they happen very often. I would say the majority of our patients had some sort of STT changes, and they are quite non-specific, and so far have resolved in all patients we saw in clinic in the sort of earlier follow-up. So to summarize, I think we should probably be, based on the data we have had so far, quite optimistic in terms of longer-term sequelae in patients presenting with PIMS-CS. So far, at least in our cohort, we had normalization of cardiac function in all our patients. I've spoken to panvalvulitis, which is also one of the sort of soft markers we see in patients presenting with this picture. We did not really see many coronary artery abnormalities in the PIMS-CS cohort, and we believe that PIMS-CS is different from Kawasaki disease. And I've spoken about ECG changes, and so far we have had no significant arrhythmia. And I've also mentioned the limited value of some of the cardiac-specific markers such as BNP and troponin. And I would like to thank all the sort of good staff and everyone who looks after these patients, and thank you very much for your care.
Thank you, Philip.
I'm just going to, sorry, Kate, I just wanted to come in with that one quick question from Gerald Hanson, if you don't mind.
Yes.
Philip, he asks, in the patients with primarily myocardial dysfunction, have you done any late MRIs?
Yes, we did. Yes, we did a couple. And I had a corridor discussion with one of my colleagues from another sort of cardiac center, and they did more than us, and then again they so far had nothing. But this is just a corridor discussion. They didn't have any sort of changes on their sort of scans that they did a few weeks after the initial presentation.
Thank you very much. Back to you, Kate.
Thanks ever so much, Philip, for that. There are a few other cardiac questions I can see, but we'll collate those and we'll get some answers. And Philip, if you've got time to have a look at some of those on the chat and respond on the chat, that would be fantastic.
Okay, I will do it. Thanks.
Thank you. So moving on now then to the absolutely fabulous Di Robertshaw, our specialist cardiac practice educator at Great Ormond Street, who's going to talk to you about cardiovascular care and being prepared for instability. Over to you, Di.
Thank you very much, Kate, for your introduction. Today we're going to, hopefully, why have I got a problem here?
Looks great this end.
Yes, right, now we've got it moving. Thank you very much, Kate. Good afternoon, everybody. My name's Di and I'm a practice educator at Great Ormond Street in the cardiac unit. And I'm going to split this session into 2 parts. One, I'm going to address really the nurses in local peripheral hospitals and also in non-cardiac areas. And we're going to do the last part. Our lead practitioner for the extracorporeal membrane oxygenation service is just going to give a brief insight into the ECMO service. So like everybody else, April last year was very significant. So one sunny afternoon in our new open plan offices, I heard one of our nurse practitioners make the comment, Oh, that's the third child this week admitted with Kawasaki-like symptoms and cardiac involvement. And Dr. Kuchera has just shown you a nice graph showing that that's exactly when PIMS TS began to kick off. On Sunday, the 26th of April, NHS England put out the alert of this novel disease. And on Friday, May the 1st, the RCPCH guidelines were issued. So we were in there at the beginning, and the learning curve has been very steep to reach this very complex situation where almost any symptom you see in a child may be related to COVID-19 and PIMS TS or any other common paediatric setting. So it was also highlighted that parents were very reluctant to take their children to hospital, and the guidelines on the traffic light system were issued in May to try and encourage people to seek help for their children. And this is particularly relevant when these children deteriorate so very rapidly. We need to be prepared for that. We are fortunate with the setup in the UK that we have well-established referral pathways, retrieval teams, and easy accessed web-based algorithms and guidance from these experts, and a good network of tertiary referral centres who were developing best practice. But overall, for most staff who had not witnessed deterioration like this in children before, it was very scary and very stressful work, particularly with the background of not knowing how very virulent COVID-19 is, and of course access to PPE and other strategies. It's so much easier the second time round. And very often when they did rapid COVID tests on the children, there was this huge sense of relief. Oh, good, the child doesn't have COVID. And we were not aware at this early stage of the severe inflammatory effects. But we were very wary when the child appeared fine and then suddenly deteriorated. And so I'm going to focus on the cardiovascular aspects. For many of us, the familiar is often our security blanket. And for assessing these children as they arrived in our paediatric units, it was important to return to our basics of A to E assessment and our paediatric early warning scores. And many of our children were not presenting with airway and breathing difficulties and appeared fairly happy and comfortable. And then often their demeanour changed, they would complain of pain, abdominal upset, and sore throat, headache, and then their blood pressure would start to drop and you knew that you were having problems. We also saw children, level of consciousness was changing, they became disorientated, and occasional child had a seizure. We were also aware as the blood pressure dropped that some children with their high temperature remained vasodilated and others became cold and constricted. We saw rashes, skin discoloration, and general aches and pains. And it has been well expressed very comprehensively during today's webinar of all the likely signs and symptoms that we might be. And we've reinforced, think PIMS TS, but don't forget all the other common differential diagnoses. So what sort of problems do we have to be prepared for? Particularly the sudden drop in blood pressure and hypotension, and it becomes resistant often to treatment and continues to sag after fluid boluses. It's very important to know your normal blood pressures for age and weight, and we were seeing 10, 11, 12-year-olds with systolics below 70 millimeters of mercury. This is normal for a neonate, but not for a 10-year-old. We need early IV access, and then we need to be prepared when the fluid boluses are failing to administer inotropes. Now, this is not so commonplace in general paediatric settings, but fortunately, most of the retrieval teams have a good website. Our CATS team in London have the In a Hurry tab with the drug calculator to do all the work for you. But a warning about adrenaline and noradrenaline. When we use it in intensive care, it's a much stronger solution, which we give via a central line. The peripheral dosing is a weaker solution run at an increased volume. And for those of you who haven't experienced the extravasation of inotropes via a peripheral line, they are all severely vasoconstrictive. They cause subcutaneous ischemia, tissue necrosis, and often quite a large area that will need very careful management, tissue viability, and subsequent skin grafting. So very careful administration. And as the CATS team highlighted, one of the important things is that you have a good line, that the site is observed frequently, and that you have three-way taps in the lines to make it easy to change over to different fluids. And for any child with a low blood pressure, you're going to have organ perfusion issues, and therefore you must be very aware to observe reduced cerebral function, renal function, and gut perfusion. Now, related with the low blood pressure, your cardiovascular issues are also going to deteriorate with reduced cardiac function and your multi-system poor perfusion. And as the diastolic pressure drops, coronary artery perfusion reduces, and with the children with potential cardiac abnormalities, with coronary arteries and myocardial damage, you will also be noting that there are increased cardiac markers, troponin, BNP, and the lactate is usually rising. ECG changes we're going to talk about in a couple of slides, and arrhythmias will be common, and cardiac failure may present as an acute situation. And again, organ perfusion is going to lead to further physiological instability. And these children at this stage often start to have vomiting and diarrhea. So what causes arrhythmias? We have 5 known causes. The first 3, hypoxia, ischemia, acidosis, and electrolyte imbalance, are reversible, and therefore constant monitoring of the levels for these is important. But COVID, of course, causes infection and inflammation, and the myocardial damage is what reduces and irritates the heart so that you get more arrhythmias. The less concerning arrhythmias, sinus tachycardia, is considered normal in a sick child, but atrial ectopics, junction rhythms, occasional ectopics, and as Dr. Kuchera has outlined, some heart blocks are also seen. We would be much more concerned if we saw SVTs, which in the first wave we did, lots of ectopics, runs of ventricular ectopics and ventricular tachycardia, and several children before they reached critical care did have short arrests. The second time round we're better at treating, and then we've seen much less of this. So here's some examples. These 3 rhythm strips were taken from children who came to our cardiac day unit for review from other hospitals where they've been inpatients, and they were seen by our multidisciplinary team here. One young lady presented with sinus arrhythmia, where you see increased heart rate, decreased heart rate, and then another spurt of increased heart rate, and this is related to respiratory pattern. I looked one day on the nurses' station and found this ECG with lots of atrial ectopics, and from a distance it did look very irregular. And this young lady is still under follow-up. She's had 24 and 48-hour continuous ECGs taken, and she is still showing lots of atrial ectopics. And we also were seeing frequent ventricular ectopics, which were normally physiologically related. What we don't want to see are these random varied ectopics that show great irritability in the heart or multiple runs of ectopics. And these will often lead to ventricular tachycardia and VF arrests. We've also been discussing earlier in this webinar the coagulopathy problems, and it's important to assess your prothrombin, ferritin and D-dimer levels and treat accordingly as was outlined. But the risk of thrombi is very important, again, in major organs and particularly in the limbs, the digits, and clotting in particularly where you've had invasive therapy. And for those children receiving some sort of anticoagulation, you've then got the reverse problem of looking for oozing and bleeding from all their orifices and particularly in their urine. So the message is, be prepared. Cardiovascular instability needs a very quick response from a collaborative team of players to avert collapse. So perhaps the message is a high index of suspicion and anticipate deterioration, then you'll be ahead of the game, and a very low threshold for expressing concern and seeking help quickly from appropriate equipped people. And just to finish with, what are our strategies? Obviously, to maintain a COVID-safe environment, to seek help early, continue observations and your multi-system assessment, to screen for sepsis, to have all your blood samples taken for blood chemistry, inflammatory markers, and where available, standard cardiac recordings of ECG, echo and CT when there's concern. And as has been previously alluded to, the heart, if it is being compromised, will often fail quickly, even with small boluses of 10 mils per kilo. And you would need to take advice from your retrieval teams as to how to proceed. Give medications as advised, but very importantly, as the CATS team advised, you need to prepare the parent and carer for what might be coming, because as soon as they hear words like adrenaline and transfer to a cardiac unit and potential mechanical support of their child's circulation, they become extremely fearful. And I think the parent that spoke earlier really conveyed that very well. The inotropic support is extremely important, and support of respiratory status as required, and we've heard this is not very common, and transfer to the tertiary PICU. That will continue with a multidisciplinary assessment. They will check the SARS-CoV-2 serology and continue to specialist screening and assessment for mechanical support of their circulation. And their aspects of care, particularly for the care side, is related particularly to infection control and observation of the child, respiratory management. They often have very poorly perfused skin, their eyes have been sore, their mouth has ulcers, and they need careful care. Their tissue viability is very fragile, and particularly limb and digit perfusion should be assessed. We mustn't forget gastric protection, and for the older children, thromboembolic protection and compression stockings. Observe for oozing and bleeding and for thrombi, and very careful positioning. Physiotherapists will talk more about that, I'm sure, later. And involve the family members as far as possible and establish a good communication strategy with them. And as we near the end, we also must think of de-escalation of care. And it is amazingly how quick some of these children arrive in extremis and within a couple of days are on their way up to the wards looking a whole lot better. But beware, because that's the time when you need to be very vigilant. And we've had several children that have had seizures post-ITU experience, or who've had to return to ITU because of hypotension again. So my last part really is about family and staff support. So life-changing events very much revolve around the big C's: cancer, cerebral compromise, cardiac, and now COVID. And the media statistics are not really very helpful as they focus on mortality. And everyone says, you know, it's fine, you know, children don't really suffer from COVID, and, you know, the mortality rates are very low. But if you're a parent with your child on the way to a paediatric intensive care unit, it's 100% risk as far as they're concerned. So support is vital. As was mentioned earlier, the psychological support post-critical care. And you'll have an opportunity to talk to one of the psychologists in the panel and pose questions about the issues that they've experienced. And as I say, the cardiac symptoms instill fear, but when they also mention assessment for extracorporeal life support is one of the reasons why they're transferring the child, that reinforces the severity of the situation. And it was mentioned earlier about leaflets for parents and children, and Great Ormond Street also have a series of leaflets which are on our open access website if you want to have a look at them as information. So I'm now going to change screens and hand over to my colleague Maura O'Callaghan so that she can tell you a little bit about ECMO.
So over the next few minutes or so, I'm just going to talk about ECMO for children during this COVID-19. So the severity of COVID-19 is related to hypoxic respiratory failure, prompted the World Health Organization and the Extracorporeal Life Support Organization to consider the role of ECMO during the pandemic as a lung protective strategy. And as you've heard over the course of the day, and I'm sure from Di earlier, that within children, COVID-19 may have less severe respiratory disease, but severe disease can occur, and that's what we have to be prepared for. There's also a small subset will develop hyperacute inflammatory syndrome. Hit it several times. Put the cursor on here. Just click on there and then hit down. Okay, okay, so apologies about that. So thinking about ECMO support, there is criteria for ECMO support and it didn't change during this pandemic. And basically ECMO just supports the body while you're trying to get recovery. So with your antibiotics, with all of the other combination of treatment that you're going to be using. So basically the criteria is that you have a potentially reversible respiratory disease, failure to respond to maximum conventional therapy, and a low or failing cardiac output resistant again to maximum conventional management. There's also exclusion criteria, so irreversible CNS injury, major immunodeficiency would be an exclusion criteria for pediatrics. So what do the adults have for themselves as their criteria? It's very, very similar. So again, you're looking at potentially reversible severe respiratory failure. They're looking at uncompensated hypercapnia, so that they're retaining CO2. And you will see in the second case that I'm going to talk about today, that was one of our problems with the little girl that we were looking after. That they failed to wean from ventilation in the prone position for greater than 6 hours and failed optimal respiratory management. Again, there's exclusion criteria. So again, refractory to established multi-organ system failure, evidence of severe neurological injury and prolonged cardiac arrest greater than 15 minutes. So you can see there's very little difference between the two. So I've got two quick cases just to go through with you. And obviously I've changed the names of the children. But Tanya was an 11-year-old little girl. She was of Asian origin. And this little girl presented with true PIMS TS before it was ever described. So this was right at the beginning of the first wave. So what was her history? She was previously well. She'd suffered with mild asthma and was being treated with salbutamol. And she just developed a cough and fever and didn't improve over the next few days. So on day 3, she had this abdominal pain, fever and diarrhea, and she went to her local hospital. This abdominal pain was significant. She had a CT abdomen and that was NAD. And she started on usual treatments as antibiotics. And this is the thing with children, is this rapid deterioration. So just a day later, she's deteriorated, she's in shock, she's got a lactate of 7. She was fluid resuscitated with 60 mils per kilo, intubated and ventilated and given inotropic support. She was noted to have persistent diarrhea, red conjunctivitis, and she was COVID-19 positive. And she had a 3-minute cardiac arrest and was given IV-IG. Oops. So Tanya was referred for and went on to ECMO support. And just to give you her results, as you can see there, her D-dimers, all of this has been spoken about over the course of the day, her CRP, her troponin, look at those ferritin levels and her vitamin D. As I said, she was transferred to us and she went on to veno-venous respiratory ECMO support. These children have fairly long runs and she was on for 2 weeks. She recovered, came off of ECMO and went back through the ICU. The second child is, again, names have been changed, is Bailey. She's a 5-year-old, again of Asian origin. And this little girl had COVID pneumonia. So she had a history of brittle asthma, bronchiolitis obliterans, and had this awful history. She'd been admitted to ICU 6 times over the last winter, intubated and ventilated every single time, and had this unusual or severe response to viral infections. So a bit worried about when we got her referral. But she had a 4-day history of increased worker breathing, and a lot of that was put down to this asthma and her reaction to viral infection. So increased her asthma therapy. She was given high-dose steroids and nebulizers. She just had a 1-day history of fever. On day 1, she was admitted to her local worsening respiratory failure. Chest x-ray was slightly worse, not really too bad, some new infiltrates, but she was desaturating and she was intubated and ventilated. Again, antibiotics were started and steroids, and she was transferred to an ICU. Day 3, rapid deterioration. She was referred for ECMO. Look at that pre-transfer gas, pH of 7, CO2 14. Her lactate was okay. So COVID pneumonia compared to the child earlier that had PIMS-TS. Again, she was on ECMO support for 20 days. In both cases, there were no concerns with ECMO support, and she was prone positioned nearly on a daily basis, and both children came off support and went back through ICU. So again, there are her blood numbers, as you can see. So ECMO is very invasive. There is an awful lot of COVID-19, PIMS-TS, but very few children have gone on to ECMO support. So thousands of adults across the world. In Europe, I think there's about 10 children have gone on to ECMO. So in summary, we've supported 2 children on ECMO. The first case was a true early PIMS-TS seen in the first wave, and the second child was COVID pneumonia on the back of established lung disease. We've had many other referrals, and they've included children with endocarditis, myocarditis, etc. The child, to note, the child with endocarditis died with septic emboli. And I know Di was talking earlier about anticoagulation. And anticoagulation, especially in paediatrics, especially on ECMO, we're very aggressive. And the APTT is about 2.5 times normal. This is a paper that was published in The Lancet in September last year. And as you can see there, you can see the number of adults that go on, but just the ones that are highlighted, just look at the pre-ECMO intubation days. There's only 4, so it's very, very little rapid deterioration. Pre-ECMO support, going through all your modalities of ICU support. But look at the very bottom, the respiratory numbers, 96%, very little cardiac involvement in adults compared to children. So just my take-home messages: device seeking early recognition, advice and treatment, awareness of PIMS-TS, that once these children have any symptoms, decompensation is very, very quick, and the early referral for ECMO if they show signs of decompensation. Thank you very much, and I hope I've kept time.
Thank you ever so much. We're going to move on straight to the next presentation, and we will take some questions later on. And if you lovely ladies wouldn't mind answering some of the questions in the chat, that would be fantastic. So moving on then, we're going to hear now from Dr. Karen Moschel, who is one of the ID consultants at Great Ormond Street, who's going to talk about the future ongoing and follow-up care.
Thanks very much. Sorry, can you see my slides?
Perfect. Yeah. If you just put it into slideshow, then I think we'll be
great.
good.
Hang on a sec, I seem to have okay. Right. Excellent. Sorry, I'm seeing a different view, which is slightly disconcerting.
It's all good from our end, I think, although it's still not on slideshow just yet. I don't know.
Is it on slide view now?
That's it. Perfect, Karen.
Excellent. Well, thanks very much, Kate and Adrienne, for inviting me to speak. It's a pleasure and a privilege to be talking to all of you today. And it's a slight shift in focus because we've been hearing about inpatient and acute care from admission through to intensive care and then discharge from intensive care primarily. But what I'm going to talk about is ongoing and follow-up for these children, because once they leave hospital, there is still a great deal to do. They discharged relatively well, but we have a responsibility as we have a new disease process to define this disease process. The natural history of it is still unknown. Our first patients presented less than a year ago, so we don't even have a year's perspective on what the sequelae are going to be. And although all the signs are good and our children are looking extremely well 6 months out, we do need to make sure that we're not going to be missing long-term sequelae that could potentially be incredibly important for them, and if we deal with them now, can short-circuit problems in the future. So we need to identify patterns of diseases, and once we've identified those patterns of diseases, we need to determine how best to manage them. So we are, as we are going along in real time, developing the expertise to do this, which is something that is best done as an MDT team. And just as we have developed methods of working together and developing consensus around treatment very quickly and in real time for these young people as they came into hospital, so we are going to have to do that with them as outpatients. And it's about cross-pollination of ideas, sharing of expertise from other similar disease processes and experiences in our different specialties, and knowledge sharing as we go along. It's also really important to make sure that we provide support for the patients and for the families. The environment into which they have come is incredibly frightening. They have been through a very traumatic experience in the middle of a pandemic that is new for everybody, and are the first young people to have developed and to survive this very new disease process. So we need to develop a support system for them and provide them with holistic care. We also have both an opportunity and a responsibility to develop clinical and operational research studies and to collect data in order to determine the natural history of this process and to develop an understanding of the sequelae. We also have to support our local services, and we need to balance all of this with allowing our children to return and support them in returning as quickly as possible to a normal life, or what passes as a normal life currently in lockdown. So we have a clinic which is comprised of multiple medical and allied health professional specialties, and the teams are coordinated by the infectious disease service. Now, we have a number of teams who are actively involved in follow-up of these children, but we also have a watching brief from a number of others. So actively involved are infectious diseases, neurology, ENT, speech and language, physiotherapy, psychology, and cardiology. And then we have a watching brief from our hematology clotting service who manage these children who are still being weaned off their dalteparin to a large degree, the gastroenterologists who have a watching brief over those young people who came in with abdominal pain and regional ileitis, the nephrologists, respiratory medicine, rheumatology, and immunology. And we've set up a structure to allow people to communicate with each other, to share experience, and also to look at the child as a whole, but with specialist input regarding each of them. And we do this by holding a weekly MDT team where we discuss via Zoom, which is a very useful and convenient modality for getting a lot of people together quickly for short periods of time from each of the specialties. And the patients who will be seen in the following week, and particularly problematic patients in the ward, are discussed in that. The point of contact is our infectious disease clinical nurse specialist, and I'll talk a little bit more about her later, but that person and that post is really the linchpin of the clinic and is the contact person for the patients and their parents when they go home. And in the first wave, in the first few weeks after discharge, she was getting approximately 1 call a day and was very much a lifeline for those families. Di managed to show you the patient leaflet that for some reason I couldn't download and show you, which is brilliant. It's a leaflet that was put together by the entire MDT team, and again coordinated by our clinical nurse specialist, and had a lot of input from one of our teenagers who had PIMS TS, and he absolutely loved the process of being part of developing a patient information leaflet for those who have the misfortune to come after him, and to share his experience and make sure that they were given the information that he felt was most important for them to have. We see patients as day cases for their first assessment, which was felt to be the easiest way for these young people, who some of whom were traveling large distances and still not particularly well, where they could be on a ward in a bed and comfortable, and they spend between half a day and a day being seen and assessed by each of those specialties. And that 2-week follow-up is rather important, because based on that follow-up, the decisions are made about which of those teams will see them at 6 months, 3 to 4 months, sorry, 6 weeks, 3 to 4 months, 6 months, and then 12 months. The medications are prescribed and dispensed together, all investigations are done at the same time, and scheduling is coordinated again by the ID team. And what that achieves is it streamlines the process for both the teams involved and also for the patient, so that the time spent in hospital is minimized, and the efficacy of everything that needs to be done is increased as much as possible. And it's particularly important for these young people who've been stuck with needles on numerous occasions that they have 1 needle and 1 blood draw rather than 1 per team. It provides joined up care, and it allows us as a team to share knowledge and also ask questions of each other and get information very quickly that needs to be passed on to patients. So within that context, what are we actually seeing? And it's very much, as we've learned with this disease, it's expect the unexpected. I think that I can safely say that the beginning of this process, we would have thought that respiratory issues and cardiology issues would be the major problems and would be ongoing problems post-discharge of patients, and possibly renal. But in fact, what we've seen is something slightly different. We have, as you've heard from Ming earlier, neurological problems and psychological issues, and particularly prominent have been emotional ability, anxiety and depression, and the cognitive changes that Ming has talked about. And I know that Zoe Berger, who's our lead psychologist on PIMS TS, is going to be in the panel discussion, so she can talk about some of those issues later. In terms of musculoskeletal, apologies for my spelling error, we've seen profound weakness, and Sue Mallard, who is our lead physiotherapist, is going to be talking about that after me, so I'm not going to provide any spoilers. We also see speech and language issues that initially people thought were related to admission to PICU and ventilation, but actually some of the dysphonia and voice changes predated admission to PICU and also occurred in children who were not ventilated. Early data from the ENT department suggesting that this is related to muscle weakness, but they're currently collating that data. So hopefully you will see that in more scientific form at a later stage. Currently, we haven't seen a great deal of gastroenterological problems at the 6-month stage, but we have had some children who have had abnormal calprotectins, and I think that it is something to watch, as we need to remember that these children had large doses of steroids and immune modulatory therapy, which might have dampened down some of those potential pathophysiologies that might actually recrudesce later on. That is pure speculation on my part. So I think that follow-up of these children in centres where a number of them are being seen together is really, really important, because it's only when you see a group of patients together that you can start to define the patterns of disease, and you can start to determine what works and what doesn't. And there are a large number of questions that we still need to answer. We don't know why this particular group of patients develop PIMS-TS. We don't know whether it's a host virus interaction specifically, and if so, what the host susceptibility that allows this to happen is. We have an idea of the population at risk, but we don't know why, and that is not completely robust. The age group at risk, which was one of the things that alerted us, is that in fact it's an older age group to those children who normally present with Kawasaki disease. But again, although that is, it's a wide age group, and it is potentially going to be further defined. We don't know the long-term sequelae of this disease, and we can't know because we are only 8 months in. So we don't know whether these children will develop problems a year down the line, 2 years, 3 years, 5 years. It's looking good, and the early data suggests that the number of children who will have long-term sequelae is probably small, but as we have larger numbers of children going through, we will be able to define this. And it's important to follow them without frightening them in order to define those. We don't know whether they are susceptible to reinfection, and if they are reinfected, what response they will have to that infection. Will they present again with PIMS-TS? Will they present with a more severe infection second time round with an augmentation effect? We don't know. Again, we are in the middle of a second wave, which is much larger than the first wave, and certainly at Great Ormond Street, we haven't seen that yet. So that is really good news. The antibody response, 6 months on, about 93% of our children still have detectable antibodies, but we don't know whether they have neutralizing antibodies and how protective those antibodies are. It's not a question at the moment because we do not have vaccines licensed for children, but that is coming down the line. And I know, again, Saul is on the panel later, and hopefully we'll talk a bit about vaccine studies, which are due to start in the next couple of months. So that will be a question we need to answer for our children. Do we vaccinate our PIMS-TS patients or not? This is not an exhaustive list, and I'm sure that people will have many other questions. And as we progress with these children, more questions to be answered will be raised. So we need to have some kind of structure for this ongoing care, both for us to learn as much as we can about this disease long term, for us to provide the best possible standard of care for these young people and support for their families, but also to support our colleagues in the district general hospitals and beyond, and both provide them with information, provide them with support, but do not deprive them of the ability to develop the expertise as we do too. And therefore, we need to think about what model of care we're going to provide for them. And we need to look to what we've done in the past. And I know there are probably going to be gasps out there that I can't hear when I suggest that we need to use our HIV outpatient care model. Now, it makes a lot of sense because the last big pandemic that we've witnessed as a society has been the HIV pandemic, which started in the 80s and really hit its peak, certainly here in the 90s. And similarly to this, we were presented with a new emerging disease that nobody had met before, with a natural history that was undefined in children, where we needed to develop treatment strategies and long-term management strategies. And although this is a very different virus and a very different disease, there are lessons that we can learn from the systems that we put in place then in order to manage this disease now. And we have a model where we have tertiary care clinics that support local clinics in a hub and spoke model geographically across the UK. And we have a very strong multidisciplinary team and network approach to care, which has served us very well because we've been able to share knowledge, share experience, and communicate as a team that cares for these children across the UK, which has increased our knowledge and allowed us to develop that knowledge and develop management and treatment pathways much more rapidly than if we were doing that alone. We also have an obligation to collect data and to develop an operational and clinical research study set up in order to do that in as systematic a way as possible without impacting on the lives of our children and making it too onerous for them, which is a fine balance that we need to tread. And then there's a sticky question of how long do we follow them up? How long is long enough? We don't want to over-medicalize these young people, but equally we don't want to take support away from them when they might still need it. So we have developed very pragmatically, both at Great Ormond Street, but with our colleagues at the Evelina and also at St Mary's, a basic follow-up plan, which is a 2-week follow-up, 6 weeks, 3 months, 6 months, and then 9 to 12 months, and that is tailored according to how well or otherwise the patient is. We do need to look after the families. A lot of the parents particularly are very anxious and need a lot of support, which I'm hoping Zoe will talk a little bit about later. Currently, we're looking at the 6-month data and hopefully we'll have more. I'm very aware that I'm data short on this, and we should have that data available for you in a few months. And we will continue to collect that over the 6 months to follow. We will collect that for this new cohort going through, and we should have a great deal more information within the next 6 to 12 months. I particularly want to thank all my colleagues across all the specialties who've been involved in our MDT team. And this is one of the silver lining of this pandemic for us, getting to know some amazing people and being able to work closely with them. And I'm name checking 3 people in particular: Carly Grant, our infectious disease CNS, Justin Penn, our senior ID fellow, who really are the linchpins of our MDT clinic. We would not have been able to do it without them and rely very heavily on them. And Jane Hassel, who's our neuro ID general pediatric consultant, who is ward-based, and finally my colleagues in the ID team. So thank you very much, and thanks, Kate.
Thank you so much, Karen. And there have been some questions in the chat. We're quite keen to keep to time and because we've got quite a tight schedule. So I wonder if you could stay with us and maybe just have a look at some of those questions in the chat and answer them in there, if that would be okay.
Yes, sure, with pleasure.
Thank you. So moving on to our next speaker then, to the physiotherapy team. So we're going to be hearing from Sue Mayard, who's a clinical specialist physiotherapist from Great Ormond Street Hospital, who's going to talk to us about caring for young people with PIMS TS.
Screen. This one? That one, yeah, that's your PowerPoint. Then you need to, that's it. You might need to just click on there first and then double click on there. There we go. And that's it. Okay. Yep.
Looks perfect, Sue.
Excellent. And can you hear me okay?
Yeah, perfect.
Wonderful. Thank you very much for inviting me to talk this afternoon. I'm going to do my talk around the physiotherapy experience of looking after these young people after they've stepped down from PICU. But I've also done my talk in quite a personal way as to how it's been for my journey. And and what we've learned as we've been going through this. But I also want to say thank you to my rheumatology team, who we, by chance, ended up looking after these young people. But these lovely people named here have all worked really, really hard with me to be able to provide a comprehensive service to these young people. And this picture is a picture that one of my patients drew for me to say thank you for the work we were doing in the hospital, and I thought it was very poignant. So fundamentally, beginning of March, my team had holidays planned, weddings planned, theatres trips planned, and I had a trip to Disneyland planned. And on the 20th of March, the 13th of March, a lovely colleague in the middle of clinic gleefully told me Disneyland had closed without realising I was about to go there. And then my holiday promptly got cancelled. And then everything got locked down. And London then became extremely quiet, which was unbelievably odd. And normally I'm a rheumatology and a pain specialist, and we run a rehabilitation program for young people with rheumatology and pain conditions. That is a group program, so that promptly got stopped. All of our outpatient clinics, like everybody else, got changed to virtual or telephone clinics. And then, you know, fabulously, we had access to the electronic patient records and other remote systems so that we could do that. But because the large bulk of our work in the hospital, which was the rehabilitation program, closed, I offered that my team would look after general paediatrics, was moved to the hospital, and that we would provide a service, which was you know, itself a really fascinating experience, and I had to learn lots of new treatments I hadn't actually used for far too many years to mention. And then a few weeks into this, suddenly I discovered a hedgehog ward, which I discovered by chance because it sort of popped up on Epic. And then I worked out that it was the designated ward for the COVID patients. And because we were doing general peds, it was coming under general paediatrics. So we, you know, cheerfully walked into that ward to find out what we needed to do. But actually it was an entirely new team, a new team of nurses and doctors who hadn't really worked with each other. We were completely new to everybody as well. We're all in PPE, so the only way you could see somebody was their eyes. And luckily I have quite outstanding hair and I wear rainbow boots, so I could at least stand out. But it's very difficult to meet and get to know new people. It was a new ward. We were all working in PPE and working out what that was, which was really very stressful on the hedgehog ward because we were in contact with patients who had COVID. And also it was then a completely new disease and no one really knew what was going on. So we went in there with open minds to examine and assess these young people to see exactly what we needed. And what we found was that these young people were very, very tired when they came from PICU, much more tired than I would have possibly imagined for somebody being in intensive care. They also had very weak muscles, cardiac instability, some respiratory involvement, reduced mobility, and then there was a psychological impact upon the children and their families. But we also were working in two teams, so it had been decided that half of my team should be at home doing all the virtual and half in the hospital doing all of the inpatients, and then we swapped over. But because my team are so fabulous and we communicated all the time, one team would start to pick up things within these patients and tell us when we were out, and we would come in, see the same thing and build on that knowledge. So we were then able to really pull together what we were able to do for these young people. And so looking back from the first wave, we actually saw 50 children who were admitted to our ward. 36 of them had been to PICU, so not all of them. And I'm sure you've seen some of this data, but basically they're an average of 4.6 days in ITU. And overall, they then stayed in hospital for around 11 days, slightly more girls than boys. And we actually at that point had an age range of 5 weeks up to 17 years, but the mean age was 9. And most did not have a pre-existing diagnosis, but as you can see here, a few of them did. So as I mentioned, we were piecing together what we were seeing on assessment, and what we had to be really careful with was their cardiac instability with movement and changing positions at the very beginning. And that was something that I think the whole team weren't entirely ready for, and certainly the nursing team weren't really ready for that. And you know, we did learn very quickly that we needed to limit mobility and not rush into the children getting out of bed and going to the toilet and coming back again, because often they didn't actually get back again. And then they were absolutely wiped out for the rest of the day, and we couldn't do any other treatment. So we very quickly then worked out a system where, as physios, we decided how much activity the patient should do getting in and out of bed, depending on respiratory symptoms, cardiac stability, and their muscle weakness. And that way we were able to support the nursing team much better. We also recognised that they had some really profound muscle weakness, and at that point it seemed that they were proximally weaker than they were distally. And we also obviously spent quite a bit of time with the families, more than probably everybody else, because our treatments took longer. So we definitely spent more than 15 minutes per session in with each patient. But because we were actually the rheumatology rehabilitation team, we decided to stick to what we knew. And so we used our outcome measures that we were comfortable with. So we looked at range of movement. We used a manual muscle testing of 8 muscle groups that looks at distal and proximal muscle groups and gives you a scoring system out of 80. We used the Childhood Myositis Assessment Scale, which uses measures of fatigue and stamina as well as function. We looked at routine respiratory function, cardiac function, because fortunately all the children were still on monitors. We did a gait analysis once they were able to start walking, and then we realised that actually we had to get these children fit to go home, and so we had to work out with infection control and the hospital how we would practice stairs when they weren't supposed to be leaving their room. But luckily there was a set of stairs that was almost not used right by Hedgehog Ward, so we commandeered that and we kept it a COVID safe staircase so that we could get the children home. I mean, some of the children needed to do 3 flights of stairs to get into their flats, for example. And that was something that took everyone a little bit of time to be able to recognise. And in this group of patients that we saw, when they came down from intensive care, they were very weak. So 80 is average muscle strength for any age and size of young person. And the mean average strength they were scoring was 56. So you can see they were significantly lower than average for their muscle strength. The CMAS is, for normal children, should you score 52 out of 52, but these children, the mean score was 20 out of 52. So you can see stamina as well as strength was really affected. And some of them were extremely weak. I mean, they could not even roll over in bed. So we provided physiotherapy treatment after the assessment, and we looked at respiratory physio, so bubble pep, breathing exercises, thinking about positioning so we could maximise their functioning from that perspective. We also looked at their mobility and progression with safety of postural changes, so looking at how they could get from lying to sitting, sitting to standing, walking, and then progressing to the stairs. And we also provided muscle strengthening exercises, and we made those very specific and functional because that's how we manage them in rheumatology in the pain service. But we found very quickly that they were limited by fatigue. So we couldn't do very much, and we therefore had to go twice a day in order to help the young people progress. And if they'd lost range of movement, we therefore worked on their range of movement as well. So our experience in the first sort of stream of COVID PIMS TS was that we had to set up an extremely new service very, very rapidly with different specialties, different people that I'd never even met before, in a completely new team, learning to work together in PPE, in a new ward with no meeting set up. And so very quickly we developed safety huddles, psychosocial meetings, and we had almost no preparation and no one else to learn from as to what we would be able to do in looking after these young people. And then, as you've heard from Karen just earlier, is that we've now followed them up, and the outcomes at 2 months was that amazingly, most of these children ended up improving their strength dramatically. So brought up their MMT8 to 72 and their CMAS up to 46. All of them had full range of movement. They still reported some fatigue, and there was still quite a lot of psychological issues, trauma, fear of going out, fear of going back to school, etc. And 75% of them we felt needed an ongoing physiotherapy program. We've now looked at the 6 months, but I'm afraid I haven't analysed all of the data, but fundamentally about 25% of them still have reduced muscle strength, still reporting fatigue. But what we're seeing is that the children who haven't kept up their exercises, haven't regained physical activity, and are still spending a lot of time in the home, very scared to be physically active, are the ones that are showing, maybe unsurprisingly, this weaker muscles and weaker stamina and fitness levels. And we've also found a few of them that have been so weak that we would have offered them our intensive rehabilitation if it actually hadn't been closed again due to the second wave. So they're still on our waiting list. So after the first wave, my summary was that we noticed many of these children were very weak, that they required physiotherapy, that we managed to get them functionally well by discharge, and a few needed virtual rehab. Some of them have remained with ongoing issues, and they needed a home exercise program, and we really needed to give them lots of reassurance and advice about getting back to school, sport and activities within government guidelines, obviously. And we've, as you've heard, set up these regular follow-ups with our other specialties. And we actually now examine joint range of movement, the MMT8, the CMAS. We've added in the 6-minute walk test, a neuro examination and a gait analysis for all of the patients coming through these follow-ups, which has been, amazing. And we've also seen a couple of patients with long COVID, but I won't talk very much about that. And now we're in the second wave, and I do, I'm sure, look quite exhausted because we really are in the second wave. And a colleague very kindly told me this morning how exhausted I look, so that's really helped my confidence. But this time we've learned a lot as a trust, and I think things are very, very different. So PICU is PICU, and that's been fabulous. But now we've got Pelican ward instead of Hedgehog ward, and we know much better about what we're doing. So the ward has isolation cubicles, it's just set up an HDU unit. We have a lot of confidence with what we're doing with PPE. I know a lot of the people now, so that makes a really big difference. The team's in place, we know what we're doing. January the 4th, we stopped rehab, and we've stopped all our face-to-face clinics, and in fact, we've been allowed to then start all of the work that we're doing with these young people. We have a better understanding of the disease. We already know what outcome measures we're using, and we've already learnt from longer term what's effective and what's required. So obviously there's a medication to stabilize these young people, but actually the whole team recognises the importance of the exercise therapy in order to get these children as fit and as well, so we can get them out of Great Ormond Street as soon as possible and back home, and then so that the young people have got a treatment they can work on in order to regain full function and stamina again. And actually, we're really much better at communicating about when it's safe to discharge these people. So the physiotherapy following step down to PICU hasn't changed an enormous amount because we learned a lot at the beginning, but we obviously need to look after respiratory assessment and treatment. We need to be also very careful of the safety of mobilisation, and that is still very, very paramount to every single child that comes down to us, thinking about how their blood pressure is changing, etc., thinking about symptoms of particularly of dizziness that the young person's experiencing, and making sure that we reassure and advise nursing staff and the parents. But tiredness is still absolutely paramount and very limiting to anything and everything we do. So we're still having to, they don't have enough energy when they first arrive to play and do physio. So we have to do less physio and less playing so we can get both in. We've also noticed significant cognitive changes. These children are really struggling to answer questions appropriately and in a normal, timely manner. And lots of them come back and they're very scared, very concerned, very low in mood. We're also seeing neurological changes, so peripheral neuropathies, coordinational changes. Often they don't stay for very long in a way to limit an enormous amount of function, but they're still there, and we still need to, be really mindful of that. And also, in the same way as before, we spend a lot of time in the room with the family while we're treating the young person. So we spend a lot of time listening and talking to the parent, because they're only allowed to be on their own, and that's been very difficult. So actually, just to pull this all together, is that, I actually feel I've had a very, very privileged experience. It wasn't designed. I feel like I sort of fell into it, and I was very lucky to be allowed to carry on with this. I do hope this is fairly unique in my lifetime, but I've really valued the generosity of experience, knowledge and ideas of everybody within this new team, my personal colleagues and the wider multidisciplinary team. And the team has grown and developed so that we can provide such a comprehensive care to our patients with, I believe, such really good outcomes, and that's been amazing. And we really are working together as a true MDT, with everybody's experience and knowledge really listened to and respected as well, which is, again, fabulous. And I think the other thing is the children are inspirational. They're inspirational in the way that they are and the way that they recover, and the joy it is to work with them and to see them improve and develop. And because the recovery is actually relatively quick, they feel very positive with what they're doing. But I think we also need to be really mindful of what the parents have gone through and their experience, their child in intensive care and one of them alone, and then coming to a ward where they're very isolated. Often they're not allowed to go out for a very long time. So I think really looking after the parents is important as well as the children. But I guess my final statement is it's been an absolute privilege to gain experience looking after these young people. And thank you for listening.
Thank you, Sue. That was really fascinating. There are a couple of questions that I wondered if you could just answer before you head off. So one of the first questions was, did you notice the weakness and I suppose fatigue in the children who weren't admitted to ICU as well as those who were admitted to ICU?
Yes, I would say that's been fundamental across most of the young people we see. I think if they've been to intensive care, certainly at the beginning, I think they stayed in intensive care but perhaps a little bit longer while everyone, including intensive care, were working out what was going on with these young people. But absolutely now, in this new wave, not all children are going to intensive care, and they're still very, very weak and very fatigued. So I think it's very much part of the presentation of PIMS TS in my experience.
Thanks. I think that's interesting, and I would, from my ICU experience, I would agree that that's probably true. And then that sort of leads on to the next question, and I think you've partially answered that, was the fatigue just fatigue, or was it a post-exertional malaise, as in chronic fatigue syndrome?
I don't think it's related to chronic fatigue. I mean, what happens in long COVID, that's another discussion, but the patients that we're treating now, I mean, I've never seen such exhaustion in children. You do 3 exercises and they almost can't keep their eyes open. They are, absolutely shattered. And, you can't really rouse them after that once they've got to that point, which takes almost nothing to begin with. Yeah, that's why we've had to see them twice a day and do little and often. Fortunately, that does improve relatively quickly, and we've been, we're able to see quite a difference after a few days. But to begin with, I mean, it's really the most profound thing I've seen. And I've seen lots of children with chronic fatigue. I've seen lots of children with chronic pain, lots of children with inflammatory diseases, but this fatigue is out of proportion of everything I've seen.
Thank you. And then I'm going to be cheeky and ask you one last question.
That's okay.
And I think, again, from a network point of view, it's really relevant, is that people who don't work in big children's hospitals and don't have all the privileges that we do often don't have 24 or even 7-day-a-week either physiotherapy, occupational therapy, but they are sometimes seeing these children who don't quite reach the threshold for our specialist centres. What advice would you give to those teams?
I think my advice would be to do a good assessment at the beginning when you can first see them, and then work with the parents. The parents are really desperate to do something helpful. They've often been in a, they're in a situation, they're very scared about what's happening to their child and they don't really know what to do. So I think in that scenario, when you're not able to provide the, treatment in the same way that we are, I would set an exercise program for the parents to do with their child, but little and often, and go and check as regularly and as often as possible. And I think, helping the nursing staff realise that the fatigue is really quite significant, and not to try and push too much in the way that we would do with other young people, so that they can use their energy fairly equally over the day, so that they need energy to eat, they need energy to speak, to play, to do their exercises, to go to the toilet, to shower. And so maybe setting timetables so that they're not overdoing any one activity might also be a really helpful way of, working out in the district general hospitals.
Amazing. Thank you very, very much for an interesting presentation and for staying on a bit longer.
My pleasure.
Kate, we can't hear you. I don't know if that's your microphone not working. So I'm just going to jump in just in case there is something that's gone wrong. So our next speaker is Dr. Owen Miller, who's a paediatric cardiologist at Evelina London, and also the co-clinical director for the Evelina London and Guy's and St Thomas's CHD network. Thank you, Owen.
Is that screen shared, Harriet?
Yeah, we can see it. If you could just make it a full slideshow.
How's that?
Perfect. Thank you.
Okay, so thank you for giving me the graveyard shift. I'll just check whether anyone's still online or whether it's just you and I, Harriet. But if there are other people,
750 people, Owen, so
okay,
you've still got an audience.
So I just start by saying, look, I'm a cardiologist, but clearly this is, as you've heard today, this is not a cardiology problem. It requires a comprehensive approach, an MDT approach. But what I'm going to talk a little bit about is service transformation. And so the way I'm going to talk about service transformation is in the true Evelina fashion. I'm just going to call a friend. So what I've done, I've spoken with other co-clinical leads in the PIMS service, Ronnie and Jenny and Julia, and we said, well, let's put together a couple of things about what we've learnt. And so I'm grateful to them for their input into what I'm going to say over the next 10 or 15 minutes. So we've seen something similar to this afternoon. We've seen that back in the spring of last year, we saw a surge of cases. And this was, as I think John said earlier, at one stage we had 18 patients in hospital at one time. That put an enormous strain on existing resources. So we had to do something, and we had to do something fast. So we had to look at service transformation, and we had to respond really quickly. And so we put in place some fast track reconfiguration. Now, some of us as clinicians, this is not natural or not normal or not commonplace for us. And so we need some help with this. But we needed to look at specialist PIMS teams. We had, for example, in cardiology, we had the whole congenital heart disease program still running. We were taking cases from other centres. We were still doing congenital heart surgery. So we had to hive off a team of cardiologists who were going to manage just the PIMS group of cardiac patients. We had to then get the PIID, the rheumatology and neurology teams who had all of their normal work to do. We had to say, okay, there is also this new condition which requires a lot of attention. And what we took, I have to put my hands up, we're a little bit slow here. What we didn't realize for the first couple of days or a week or so was that actually the key to this is general pediatrics. General pediatrics is the key to the well-functioning MDT. And I think we missed that for the first couple of days as we were concentrating on patients on the ICU or patients with shock. So one of the first things we did, we stood up a daily MDT, runs 7 days a week, and it still runs, and we've been doing that as required for the last year. We had to then define what the terms of reference of that MDT were and what the SOP for that was. So we said, well, other people are doing this. Let's learn. We have good MDTs in the hospital already. Let's look at what they're doing. Let's look at good practice. Let's look at bad practice. And let's try and learn from that so we can set up a good MDT. Some of this is described very nicely in this article in archives. So then we had to think a bit laterally. We had to do this rapid system-wide reconfiguration. And Ronnie Chung's is sort of a black belt in this sort of thing. And so we learned a lot about doing things using Agile, Agile is a process used in business and in software, but applied to healthcare can be really powerful in terms of organizing teams, having cross-functional flexibility, but also having rapid cycles of change. And so we said, okay, this is what we're going to do. We're going to prioritize the patients over the process. We're going to do things differently, but we're also going to go back and say, did that work? And if that didn't work, how are we going to change it? So over those first weeks when we were really busy clinically looking after these children, we were also changing the whole system on a regular basis. We'd write a pathway and a guideline, and would involve clinicians and our pharmacy colleagues. Pharmacy worked overtime on this. We were reviewing the evidence. We were asking other people in other centres around the country and around the world what they were doing. We're developing a pathway, and then we were trying it and changing it. We had to manage referrals which were coming in via our own paediatric emergency department, via colleagues in South London, via DGHs across Southeast England. We had different referrals. Some of them were really sick, brought in. They were the easy ones almost, brought in by STRS into the PICU. They had a really well-established, well-trodden pathway and were managed beautifully. But then there were others where were sitting somewhere. Did they need to come? Could we manage them locally? And so we had to work out who to bring in, who to manage locally, and then who could we repatriate, who could we discharge, who could we make space in the hospital, who could we send back to local or send home. So we had to define new pathways. We also were conscious that if we built some structures, put some structures in place, then they needed to last in case we did have future waves. So I'm going to show you a timeline here, and this is from our article in archives about this service redesign. And these are patient numbers, but it just shows you some of the things. Down here is the pathway. We had a clinical protocol first developed, but they had about 10 iterations in this period. Medication protocols, network referral pathways. We had to set up some infrastructure, some admin, some clinical support, venous access, I know that's been spoken about. And we had to uncouple some of our clinics from face-to-face to virtual. So we set up both face-to-face and virtual clinics. And we had to look at the staffing. Everyone was stretched. In every hospital across the UK, everyone was stretched. But we set up PIMS teams, nurse practitioner teams, overnight medical cover was doubled. So we had to look at all those things, and we had to do them all simultaneously. And then we had to go back and say, is this working, or do we need to change it? Now, this is just a little graph of the blue is adult COVID at Guy's and St Thomas's, and the red is PIMS TS at the Evelyn London. And we know back there that there was a time delay, and we know there was a peak in May. And this is where we are now. This is adult COVID at Guy's and St Thomas's, and this is the unknown. So we know it's going to happen this week and next week and the week after, and we're just unsure of how high that peak's going to be. But because of the work we did last year, these things are in place. We've got a medication protocol. We've revisited it. Our chief pharmacist is looking at the evidence. We are changing things. We're looking at what's published. We're looking at other people's experience. We're changing what we're doing with steroids. We're changing what we're doing with biologics, and we're reviewing that on a rolling basis. We have a clinical protocol, and it's in about version 10 at the moment. But everyone's included in that consultation, and it's being updated. Just last week, we stood up our venous access team again. That had been stood down in the summer, but we had it in place, and now we've got venous access. We've got a list every day to put PICC lines and central access in children every day by the IR team. Our follow-up clinics have been running continuously. We run them twice weekly, but as I said, we've also uncoupled some of the investigations. So for our well, stable children, we're uncoupling the investigation. So they come one day for their imaging or their bloods or their other tests, and then we do a virtual follow-up for the well, stable children, so we don't have to bring them into hospital for a face-to-face consultation. And this was all set up a year ago, and now we're just re-implementing it in the second wave. We saw, and this has been touched on earlier by many speakers, we saw a different age and ethnicity profile. We saw these were older, in our group, males, a larger proportion of Black, Asian and minority ethnic ethnicities. And we also looked and did some work on social deprivation using the index of multiple deprivation, and we looked at key worker families. All of these were risk factors. Just looking at ethnicity, 25 per 100,000 were from a Black ethnic group, 6 per 100,000 from Asian, and 18 per 100,000 from other, compared to only 2 per 100,000 from white ethnic backgrounds. So this was, you know, I think others have seen this, but it was startling for us. Also here, these teenagers were often young men of 80 or 90 or 100 kilograms, and they were coming into our PICU or onto our ward. And this was a challenge for all the team to manage these adult size people. We also noticed a striking high incidence of PIMS in key worker families, and this is coming out soon. I then led a pan-European study. We recruited 55 centres, 17 countries across Europe. We did a rapid snapshot over a 2-month period, 2 to 3 month period in the spring last year. We got 286 cases, all of them with cardiac investigations. And we saw a very similar age gender pyramid as we saw in London. We saw high incidence in some countries, the United Kingdom, Spain, France, Italy, but there were cases all over Europe. We saw in Europe, the peak was also late April, early May. Now we saw a lot of cardiac dysfunction, about 90% across Europe. A lot were presenting with shock and arrhythmias and coronary dilatation. So you've seen presentations this afternoon, and you'll see presentations on other webinars, and you'll see them in other publications. I don't think we know the answers yet. I think the reports, it's early days. We are going to see variation in the reports of how much cardiac dysfunction there is. And I think we just need to remain open to that for the moment. In the first wave, we did a lot. Everyone got echoed, CT'd, MRI'd, and had biomarkers. This time, well, we're doing less echo. We've got a more structured, less frequent program. There is a pathway. We're limiting CT to those with acute coronary dilatation. We're not doing as much MRI now. We did do it in everyone initially because we weren't sure what was happening. And we're limiting our biomarkers. In a publication by one of our department, Paraskivi and James Wong led on this, we looked at multimodal cardiac evaluation. Everyone had echo, everyone had CT, and everyone had MRI. What we found was LV dysfunction was common, but it wasn't the normal, usual LV markers, LV function markers that you can do, shortening fraction, 2D ejection fraction. It was the more sensitive stuff, 3D ejection fraction, strain imaging. We saw that the worst day was day 7 after onset of illness. So children were coming into hospital at different stages, and therefore you had to be clear when the illness started to be clear of when the illness was going to be worst. Just a couple of images. We saw coronary dilatation on CT and echo. This is the left coronary artery. And we saw that not in everybody, but with increasing frequency early on. We also, in some cases, saw myocardial infarction. This is a transmural infarction in a teenage boy who presented with PIMS. In summary, the cardiac findings, and I'm not going to redo Philip's excellent talk, but we saw shock and LV dysfunction frequently. We did see that the more advanced modalities like 3D ejection fraction, tissue Doppler and strain were more sensitive. And this has implications when we think about, can we devolve the echocardiography away from the level 1 center? 3D ejection fraction strain imaging is not routinely available in DGHs for children. So we have to think about that. Coronary dilatation was frequent, but it's a different pattern to Kawasaki. CD was incredibly helpful. We see some coronary dilatation down here, but this is all seen well on echo. But if we didn't see it well on echo, then we'd go to CT. MRI was useful. I saw some questions earlier about MRI, but the more research-oriented things like MRA strain was abnormal in 35%, myocardial edema we were seeing in half the cases, and as I showed earlier, myocardial infarction. Will Reagan, one of our fellows, has just published the data on ECG in all the cases and found, as was stated earlier, not much ECG change, a little bit of QRS amplitude change, a bit of transient T wave, but ST change or signs of ischemia were very uncommon. Thrombosis was a problem in some cases. This is a big boy who came across and was pretty well, and people were saying, well, does he really need an echo? So we did an echo, and look what we found. We found thrombus in the left ventricle. So this guy, this was found almost incidentally. Function was okay. Terrible LV thrombus, at risk of stroke and death. And so this was a very surprising finding. But we then looked at thrombosis in our whole group, and about 7 to 8% had some form of thromboembolic complication, and they were both cardiovascular or venous. And as John mentioned earlier, we had 2 bleeding events, one on someone who was on ECMO and one with venous access. We saw earlier, other speakers have mentioned about biomarkers, ferritin and D-dimer, and we follow those in all patients. We manage everyone with low-dose aspirin and anyone over 5 with dolteparin. So follow-up. Karen's given a very nice talk on follow-up, so I'm not going to go over that again, but our follow-up is very similar. I think Pan-London, we're doing things very similarly. But when we started out, this was uncharted territory. This is a new condition. We didn't know what we needed to do for follow-up. So we used our KD template, seeing them acutely at 2 weeks, 6 weeks, 3 months, 6 months, 12 months, and that is still evolving. We don't know what's right, but we're trying to work it out. What we've seen and what others have seen is the psychological morbidity. All families are offered psychological support, and Anne Gordon's leading on a large project where all of our PIMS patients have had a comprehensive clinical outcome survey, and that data is also being analysed. Long COVID, that's a whole new story, but we're using our PIMS group as a study group for long COVID. Right, we've disseminated the experience as we all have. Julia Kenny set up a national pediatric COVID call, second Wednesday of every month. Great call, and I'm sure Julia would be happy for people to join that. At the Evelina, we've published about 30 articles on PIMS in the last year in all of these journals shown, and we're continuing to collaborate both locally, nationally and internationally to try and understand this better. We're participating in recovery, BPSU, the BATS study that Mike Levine is running, Diamonds, ISARIC. So we're trying to contribute with our data to these bigger studies, because that's where the answers will come. I wanted to say a word or two about infrastructure and funding. This is a whole new service, and all of us are doing it in our own time with our own funding. It's not commissioned, it's not job planned, there's no PAs attached, and it's running alongside normal activity. In the first wave, sure, some of the clinics were cancelled and there was less inpatient activity, but now all of our clinics are running, all of our inpatient activity is running, and PIMS has hit a second time, and it's all happening despite business as usual running alongside. So we've found ourselves really needing more help. So we've gone to our service improvement team. We're getting we run an MDT daily, so we're getting an MDT coordinator, a database manager, trying to manage the outpatient scheduling for this growing number of children. We need to track the patients. We need to not lose the patients, and we need to try and triage and pathway manage so that some of these can be managed locally. We're all participating, as all the participants today, in education and dissemination. Just as an example, just our outpatient clinic. This is what it costs every year to run that, and this is completely non-commissioned and unfunded at the moment. And this doesn't include inpatient costs, biologics, PICU, medicines. So this is an expensive service that is as yet, NHS England, are you on the line, are you listening, is as yet not commissioned. Future thoughts? Well, I think for us, we're in a process of continuous service review and service improvement. We've got our transformation and service improvement teams working around the clock to help us do this. We're using agile theory and practice, care redesign. We're uncoupling, we're thinking laterally, we're trying to do things differently. We're tracking developments inside the organisation, outside the organisation via a fortnightly research steering group. We're trying to collaborate as much as possible nationally and internationally, and we're trying to just look at what we're doing and saying, you know, what can we change, what can we do better? At the Evelina London, we think there's still a lot to learn here, and so we're looking forward to working collaboratively on that. That's all I was going to say.
Thank you, Owen.
How do I pause share? New share, unshare, stop share. Here we go.
You partially answered one question that we had earlier about the cost of the service, but as you said,
it's expensive. It's expensive.
Perhaps just before we move to the panel, given that you've been involved in the follow-up services, Owen, are you aware of any children who've had relapses or multiple relapses?
So we've had a couple of children who have had early relapses where they may not have switched off completely. We've had one that I can remember who we thought had switched off and had gone home and came back in 2 or 3 weeks later. On the whole, however, once they switch off, we're not seeing relapse.
Thank you. I think that's probably reassuring to most families out there.
Yeah.
So I think we'll hand over to Lucy now, who's chairing the panel. Thank you, Lucy.
I just thought I'd introduce you, Lucy, because I realised that we've introduced everybody else and not you yet. So we'll hand over to Lucy, who's going to chair the panel for us. So Dr. Lucy Hepburn is a consultant anaesthetist at Great Ormond Street Hospital and clinical lead for the One Heart CHD network. Just before you start, Lucy, can everybody who's still a panelist and who's willing to take part in the panel, if you're okay to, please, can you turn your videos back on? Just so we can see all of your lovely faces. Thank you. All right, Lucy, I'll hand over to you.
Okay, that's really great. Thanks, Harriet. And what a privilege to round off an amazing afternoon of learning about this. So I'll just run through the panelists that we've got here again. Hermione Lyle, consultant in paediatric infectious diseases at St Mary's Hospital, we heard from earlier. Owen Miller, we've just heard from, cardiologist at Evelina. Marilyn McDougall, we heard early in the afternoon, intensivist and clinical lead for the South Thames Paediatric Network. We've got Zoe Berger. Zoe, have you got your camera available? We can't see you at the moment. She's a consultant paediatric clinical psychologist. We have Dr. Alistair Bamford. Yep, there you are. Hi, lead consultant in paediatric infectious diseases at Great Ormond Street Hospital. We have Professor Sal Faust, who has joined us as a primary investigator for the recovery trial. He's a professor of paediatric immunology and infectious diseases. Thank you for joining us late on. Dr. Nick Wilkinson, who we heard from earlier in the day. We've got Philip here still, and Karen, who we've heard from this afternoon, from infectious diseases and from cardiology. So we've had a lot of questions coming in via the Slido app. So I've got those. Panel, if you don't mind, I'm going to kind of guess who to direct them to. Feel free to redirect them. And I will ask you to keep your responses as brief as possible. We've got 45 minutes and lots of questions. So very glad, Saul, that you have been able to join us. The first one we've had here is about recruitment into the recovery trial. Do we have a sense whether it will be big enough to provide meaningful results? Can you, while you're with us, also comment on the protocol and your view of the use of steroids off protocol in shocked patients?
So, first of all, we've got over 152 now children randomised in the UK. And to answer the question about the numbers needed to treat, we've moved also with the amendment that I'll talk about in a minute today to a Bayesian analysis. Now, when colleagues from intensive care, Nick Wilkinson from rheumatology and others were trying to think of a severe PIMS specific trial called PIMS-TIC that went to UKRI, and then, to cut a long story short, UKRI asked Recovery to take on the whole thing and to change for children. The initial statistical analysis plan only needed 60 children in that detail, in that Bayesian analysis, to come up with answers. So the questions in recovery are slightly broader and the protocol is more pragmatic. But I think with the rate of recruitment at the moment, which is 1 to 3 or 4 cases per day across the country, actually we'll get there, and we will be able to get to a primary analysis on the length of stay and with secondary outcomes because these statistics do work. So, and I've put in the chat, without wanting to talk for hours, I've put in the chat 2 texts, one for the new amendment for PIMS-TS and one for the new drug for respiratory phenotype COVID that people can look at. And tomorrow the new guidance document will be available on the website. The link again is in the chat here. We've been able to the first randomization is 1:1:1 standard of care, immunoglobulin and steroid. But you can come into the trial whether you've received no treatment, whether you've received IVIG or steroid or both, and you can still enter the trial and then progress according to protocol. And if you were to come into the trial and get standard of care, then the immunomodulatory treatment that's been given by the clinicians, which will be given, is captured on the database and will be part of the secondary analysis. So I think we can be confident that we've got a protocol that's pragmatic, that works for district general hospitals where people are very confident to leave patients who don't need immediate treatment and to think about and to be able to randomize to standard of care, to the other end where intensivists really want and need to give immunomodulatory treatment, and people should be randomizing, moving through the protocol, and only at the end of it coming off and doing something different, which will be collected. But you don't want me to talk for half an hour, so I'll stop there and take any other questions.
Thanks very much, Saul. We'll come back to you. There is just a quick follow-up question. Can we recruit a child in retrospect if treatment has already been started with IVIG? I think you may have answered that, but can you just confirm that?
You can, and I think we've heard today multiple opinions, haven't we? Some people think steroid work better, some people think immunoglobulin works better. That just shows we've got equipoise, and the NHS Delphi, RCPCH Delphi process showed we've got equipoise. The fact is that some people are going to treat and then be able to recruit in the morning. Some people will recruit and be comfortable with whatever happens on the randomization, but you can come in at any point, ideally having had no treatment, and you can move right through straight away. But if you've already had immunoglobulin, if you already had steroids, or if you already had both, and that's different from the adult protocol, you can come in and move to the next stage available. And that's all very well explained in the guidance document, which is online. And I suppose the only other thing to say is this is truly a national effort. The Paediatric Working Group has people from all specialties in general paediatrics, endocrinology, ID, ITU, rheumatology, and representation from every UK region. So we, within that group, now incorporate all 15 NIHR regions in England, plus Scotland, Wales, and Northern Ireland. So it's been an amazing effort, and thank you to everybody involved.
Thank you, Saul. I'll move on to I'm going to fly through these quite quickly. Zoe, thank you for joining us late in the day. We met a parent earlier. I'm afraid you weren't here then. We've also had a really amazing talk from Sue, our physiotherapist, but I wonder if you can tell us what your experience of the challenges faced by parents of children with PIMS-TS has been.
Yeah, sure, absolutely. Well, we've been able to see patients and their parents both during the admission if they've needed it, but all of the children that come through the service at Gosh have had a follow-up at 1 month and seen a psychologist at that point. And, you know, there are a number of families that do very well and are coping and adjusting well, but there's this notable proportion that are really struggling. And we've noticed that parents tend to be more affected than the children themselves if we're thinking about trauma specifically. And maybe that's not that surprising if we think about many parents talk about the shock and the distress that comes with the very rapid deterioration of a previously fit and well child ending in an ICU admission. And when we look at the kind of standardised screening measures that we've used for both parents and for young people, what we're seeing is about 41% of parents fall into a kind of clinically concerning range for trauma symptoms, and about 30% are above cutoff for a diagnosis for PTSD. And that's lower in children, it's about 12%, but about 20% of those children do have above clinical cutoff for a mood disturbance in the form of anxiety and depression. But I guess for me, Lucy, it's the themes that are really interesting, and perhaps I can say something about those. So these are the themes that are emerging from the clinical assessments and our ongoing kind of intervention with families. And a number of those are similar to the types of psychological issues that you might expect to see in other paediatric populations, but there's some that stand out as different. And I guess for us, what we're seeing is many reports of shame and stigma and feelings of guilt associated with the diagnosis. As well as that, kind of increased levels of anxiety that's associated just with the unknown nature of COVID. And so the uncertainty of the trajectory of the illness and the recovery, a worry about this chance of becoming unwell again, or the long-term impact on someone's health. We're also seeing some children report cognitive difficulties. So past that acute PICU phase, they're reporting difficulties with their memory and concentration, which I think we need to kind of explore further going forward. And those feelings of shame and stigma are kind of, when we ask parents about that, they talk about this sense that the illness was preventable and that they might be perceived by others as not having kept their child safe or complying with COVID rules. And for the young people themselves, they've talked about the perceptions of others as seeing them as unclean or lacking in good hygiene, or a fear of being avoided as if they're still contagious. And that's generating anxiety about reintegration back into school settings and peer groups. So I guess we've learned that whilst there's a proportion that do well, we really do need to kind of pay attention to trauma and to mood disturbance, and to make sure that we're screening for those concerns post-discharge, and that families have access to a kind of specialist psychological service or care at the point at which they need it to help with this readjustment or reintegration back into normal life. Does that answer your question, Lucy?
Sorry, that's amazing. I'll just say as well that Ming has stayed on the line as well. He's been answering lots of questions in the chat all afternoon, but if anyone else has anything, keep the questions coming and we will get through them if we can. The next question I will pose to maybe Owen and Philip will have an answer for this. Do we know if not treating patients who are stable, but possibly on the PIMS-TS spectrum, results in adverse cardiac conditions, i.e. do missed cases matter? Owen, you've taken your microphone off. You go first.
Okay. So I think that's the unknown unknown. I don't think we know. I think we worry about cases that are brought to our attention 3, 4, 5 weeks later, saying, oh, maybe they had something, we didn't really see anyone about this, do we need an echo, do we need to see those? We don't know the answer to that. The only ones we're seeing are the ones we know about. So we're seeing the children who come and present and are managed and get treatment, and as Philip has shown, most of those recover nicely in terms of their function, and only a minority have ongoing coronary abnormalities. We don't know the group, the unknown group, who have not come to our attention and not received treatment. Philip, do you have a view on that?
So I think there is a number of patients in the community, and as you said, with milder symptoms, they will never make it to the hospital and will possibly be referred by the GP a few months later. So I had a number of referrals like this. I've not seen any cardiac sequelae in this very limited number of patients, but I suspect there is just a large number, probably much higher than what we see in the hospitals, patients just with fever for a few days and no other symptoms really, that may not have some cardiac problems that will just be undiagnosed.
Thank you. Nick, you've got your hand up.
Yeah, it was just to add that in the absence of knowing how to treat these patients and making a difference, then does it matter if we don't pick them up? And we'll pick them up later on. I guess that's a question to come back with. Would an earlier diagnosis make a difference?
That's on the assumption, Nick, that anything we're doing is of no use. It must be something we're doing must be of some use, I would have thought.
Supportive care, for sure.
That's why we're doing an RCT, isn't it? Because we'd like to know. And there's a new 6-week follow-up as well, a telephone call, which is going to include the results of the echo that's done later and a quality of life questionnaire. So we will get that information and be able to collate it.
It's looking like we'll have lots of information for a follow-up study day, so we'll start planning the next one. Marilyn.
Hi, I suppose just to sort of follow on from what Nick and Owen said, is that I think the treatment has made a difference. The children that we saw in that first cluster that John Lilly presented were very different to what we're seeing now, and we did treat them differently. So we were treating them as we treated sepsis normally, and those children had longer ICU stays. The only death was in that group of patients. So I think we have learned something about how we treat this condition, and we've seen the difference in how the children are coming through ICU. So
that's great. Marilyn, while I've got you there, there's a clinical question that I think I might direct to you that came through earlier on the chat. A 13-year-old boy, suspected PIMS, clinically improving, fever lower and less frequent, decreasing CRP, day 5 to 6 of disease, IVIG or not?
So my personal opinion would be if the child's improving, not, but I don't know if Saul has a feeling about would that be an appropriate child to include in the recovery study. Usually once the sort of inflammatory process switches off, it was pretty unusual to see it switch on again, I think is what Owen said as well. So yeah, I wouldn't, if they're getting better, start treatment at that stage.
I'll defer to Alistair, Marilyn, because he's been involved as well, and Hermione have been treating patients.
I think you have to look at the whole clinical picture, and I think that there's lots of subtle signs of ongoing inflammation that you may miss by just looking at the numbers or one part of the clinical picture. So I think what we're learning in the MDT is just, you can't just rely on one parameter to decide whether active treatment's needed. And if you do decide as an MDT that active treatment's needed, try and get them into a trial. So entering them into a recovery at that point.
Hermione, you're on mute.
Sorry. I'd agree with what Alistair said, because sometimes the CRP can be going down, but the child is still very red and still having fevers, still having a lot of abdominal pain. So it is the whole picture. But I'm very encouraged by the fact that we are seeing these children sooner. And I think, you know, they're coming with like only 3 or 4 days fever, whereas last time it was 7 or 8 days fever. And I think that's why a lot of these children were actually much sicker and had more serious end organ disease. And hopefully, because of the fact that everybody is thinking about this, we're catching things earlier. Can I ask Saul a question? I just wanted to, the uptake of recovery by families is maybe not as good as we would like it to be. Is it about 50% or so of people who are being asked? And how can we change that around? I feel it's quite complicated for families to get their head around it.
Yeah, so I think it's very variable across the country, actually. I think some centres have done really well. We've had some real success where District General Hospital paediatricians at the beginning have shown the families the storyboard and got really good feedback and gone through it. And then if as Alistair's just been saying, if the MDT then has decided treatment, people have already decided they want to do it, and they've heard of recovery and they understand it. I think, you know, as we all know, recruiting really sick children to RCTs when you get towards PICU has become increasingly hard over the years. It's a long time since the trials in meningococcal disease, which we're seeing over 90% of people say yes, and 50% for seriously ill children is I think probably right, with parents being given a chance to choice of whether to take part in a clinical trial. The alternative, which has been suggested by one of the PICU members of the working group, is to talk to the HRA about deferred consent, but it doesn't feel as if most children with PIMS TS are that sick at the start that we should be doing that. And I think that to give people the choice, interestingly, the patient information sheet, which has been revised now and is better this time round, was actually commended by the ethics committee as being the best pediatric information sheet they'd ever seen. And that was just the adult one that had been modified. I think it's really simple to understand. We don't think, nobody in the pediatric group thinks it's the best pediatric information sheet they've ever seen by a long way, but it is relatively easy for them to understand in that it's not really, the complexities aren't described, and that leaves it to the clinicians to do the work if they can. It's really complicated, Money. We could probably talk about this for half an hour, and I'm sure you've got important views.
Yeah, I've got to go and see my patients. But one other just really quickly thing to say is even if children are not going into a randomized control trial, we can still collect their data and we can still collect their blood samples through diamonds to help us to understand more about their genetics of their immune response, about their inflammatory markers and all of those things. And I actually think that is also really important. Even if you can't get into recovery, please get into diamonds and bats and all the rest of it.
Hermione, I'd ask people to try and recruit to diamonds before they even get it, because what we really need is people into diamonds before any treatment.
Right at the beginning, absolutely. And you know, that is going to help us to understand a bit more about the pathophysiology. And if you don't know about diamonds, contact me and I can put you in touch with the team.
Okay, thank you. I'm just going to bring it back to some more clinical presentation questions. We've had a couple of questions about COVID toes. It's not something I've ever spoken of before. In the hospital described they're managing them with topical hydrocortisone. Is it a more worrying sign in combination with other symptoms? Any investigations or treatments that should be ongoing? I guess that's open to any of the people seeing these children on the front line. Nick.
Yeah, we see quite a few coming through, and some of the patients already have, you know, what might be put on the spectrum of Raynaud's, already had chilblains in previous years, and we're just seeing greater numbers. We are using hydrocortisone. I don't think there is a strict guideline to this, and it's see and treat as you feel. We're not using a lot of vasodilators, just giving conservative advice mostly.
COVID mouth ulcers also being mentioned on the chat. Nick, while I've got your attention now, I'll ask you this one. It may be correct to come to Ming as well. Is the second wave of PIMS different? Are there more neurological? The feeling from this clinician was that there was more neurological or encephalopathic signs and maybe less cardiac severity.
Go ahead, Ming.
I think I have to say it's a little bit too early to tell. I think what we can probably say is that we're seeing slightly more of the COVID pneumonia in this wave compared to the PIMS, TS. So from our cohort, I would say definitively not. Of course, we might be recognizing them more, and certainly from our cohort, when we went back and looked at the 75 cases, some of the subtler encephalopathy were not considered a neurological symptom as such. So again, the recognition may make it appear more prevalent.
I would just add to that of course we're seeing a little bit more of the COVID pneumonia at the moment, and I think this refers to the graph that Owen showed, that we're still in the lag phase at the moment. So of course we're going to see some of the pneumonia, and I think we've yet to really understand what the new wave is going to show us for PIMS TS. And what we've found already is that there is a greater degree of complexity, and so there's a little bit more discussion about how to manage each and every patient.
Okay, thank you. Zoe, can I come back to you? You mentioned PTSD in PIMS. How does it compare with sepsis and children who've been in ITU with sepsis, normal old-fashioned sepsis?
Yeah, I just put that on the chat actually. So in terms of so the numbers are quite similar from if we're looking at PTSD in patients that have had a PICU admission. I think what makes it different is this overlay of feelings of shame and stigma that I was mentioning before. I think we need to see longitudinally, as if I can use that word, like we need to see over the long term whether or not people are still reporting high levels of trauma symptoms at 6 months and a year. So that's still a bit unknown, I think, as to whether or not the kind of long-term outcome is going to be different for these children families. But at the moment, in normal PICU admission, you'd expect to see relatively high numbers of trauma symptoms, but it's this kind of added layer of shame and stigma that I think is interesting.
Thank you. Zoe, via the Slido questionnaire, we had a comment about, from DGH perspective, it's sometimes difficult to convince specialist colleagues that children with early symptoms have PIMS until they've deteriorated. Hermione, I'm hoping your talk and your guideline would help people with that. Do you want to just quickly refresh anything on there, or if anybody else would like to say something about that?
Yeah, I think that we are all more on the qui-vive, really. And also with the system that we've tried to set up, I know this is just for the north sector, but the south, I think, is doing something similar, that we've given very clear advice to all our DGH colleagues on how they can get access to pediatric infectious diseases as a first line to discuss a case and you know, go through that differential diagnosis and so on. So I think people, you know, we can see these cases are going up very rapidly at the moment. As Nick said, we're heading into a second wave, which is going to be bigger than the first one. I think there's no question of that. So the numbers will be more, and hopefully they will be less severe. But I think everyone at all levels are aware of this. I guess it's also thinking about our A&E colleagues and also our general practice colleagues to make sure that all the way along the line, our surgical colleagues, everybody is aware of this. So I think this webinar today has been amazing. I can't believe so many people joined in. And hopefully, you know, it's in people's minds. And we just have to be careful with that balance, because we don't want to decide everything is PIMS and miss the other things, though. That is also crucial. So, yeah.
I assume, Owen, that you've got something similar in the south.
Yeah, so what we're trying to do is we've got a template form, a referral form. So there are cases in the DGH where people are unsure. So we're wanting them, as Hermione has said, we're wanting them to talk to a colleague, talk to PIID or talk to general pediatrics, get some advice over the phone. But if they really want to discuss it further, we've got a referral form we send them, they send it back, and then we put them on the MDT, on the daily MDT. So the DGH colleagues dial into our daily MDT, and we're talking to colleagues from all across the southeast on a daily basis with their cases. But we're trying to guide that discussion so it's not just an endless open discussion. We're giving them guidance about what we want to know before they come onto the MDT.
That's great, thank you. Right, I'm going to move on to some questions about therapies now. There's some questions about anticoagulation, in that this second wave in some adult practice is slightly more cautious anticoagulation. Would you recommend anticoagulating all patients? Are we doing it in response to D-dimer values? Any summary on that? Alistair.
Thank you. So I think before I say anything is that we really don't know what is the right thing to do, and the anti-thromboprophylaxis approach is, as far as I know, very much expert opinion at the moment. So but the approach we've had at GOSH is that we have an urgent MDT about every patient with PIMS-TS on a daily basis. That includes a haematologist, our brilliant Mary Mathias and all of her team. And they advise us, they look at the clotting result as a whole. If there's evidence of coagulopathy, they advise us on how to correct that with vitamin K. And then they advise us on the safe use of thromboprophylaxis based on the renal profile and other risk factors for bleeding. And that model's worked quite well. Our experience, we haven't had that many thrombotic complications at GOSH. We've had a couple of line-associated thrombosis and maybe some large vessel thrombosis in patients with additional risk factors. But we have approached to start thromboprophylaxis in all of our PIMS patients while they're in patients and continue that until the point of discharge. Whether that's the right thing to do or not, we don't know yet, but we'll be publishing our experience as soon as we can.
That's really helpful, thank you. And also, maybe Karen could come on to this one. Some centres seem to be using vitamin D as part of management. Have we got a consensus on that? Consensus is a strong word.
I don't think we have a consensus. We do give vitamin D to our children, which is probably pragmatic and not a bad idea in the middle of winter.
That's really great. I like the very quick answer to that. So
we've been measuring vitamin D levels in all our children as well, and actually there's quite a high incidence of significantly low vitamin D levels. So we have pragmatically given them all supplements, but as I say, there is some evidence of an association possibly.
Great. Well, on a cost and medication front, in the chat, there's been a few comments about how expensive our treatment is, and in our presentations we've heard about that as well. The cost in less well-off countries is obviously going to impact the therapies available to them. Do we have data yet from countries like South Africa or Brazil, for example, to compare UK treatment with, not the cost of the medications, the outcomes? Early? Too early, Saul?
Just one. I've talked enough, haven't I, from Karen or Alistair or Hermione?
I was just going to say, I think this is difficult because actually the amount of paediatric activity going on over this last year has been much less than usual. So we have to weigh up the way the money is being spent. Yeah, we've got a new disease which is expensive and so on, but we haven't been spending so much money on all the other things. Other children coming into hospital with emergency conditions, the numbers are much lower. So, you know, the issue I think is whether this condition is going to be coming back and coming back. How many waves are there going to be? If there are going to be more waves, then that is a big issue. But over 20 and 2021, I think it will probably balance out. You know, do you see where I'm coming from?
And I think the different regions as well have different organisations in the way they've worked it. I think, you know, it's too early to say at the moment. I think, Hermione, you're absolutely right. We just need to see what happens and keep track of everything.
Okay. Thank you for that. There have been a couple of questions about long COVID. I think actually as a spoiler, we are looking at doing a education day like this for long COVID in the future. But for now, any views on long COVID? Are you able to describe the features, maybe the mechanism and management? Is there a brain fog as described in adults? Karen.
I'm not going to speak about long COVID, but just to say that we feel very strongly that this is a different process to PIMS TS. And as a hospital-based team, we haven't seen long COVID as such, although we have obviously communicated with some of our colleagues in the community and DGHs. So I don't think that, and I'm speaking for my team really, are best placed to talk about long COVID. And we do need to make a distinction between that and what we've been talking about, which is PIMS TS.
Oh, this should be, I'm hoping, a quick one. Are there any ENT problems being seen in PIMS TS?
Yes, there are. So I mentioned that briefly. And our ENT and SALT teams have been looking at that quite closely. About 10% of our kids have had voice problems, which they think are related to muscle weakness around the vocal cords rather than damage to the vocal cords themselves. But it predates admission to PICU, so it's not ventilator and intubation related. But they have seen quite a bit of dysphonia and voice changes.
Well, this is a skewed question because our panel will come from large centres, but should all of these children be treated in centres with large cohorts, for example, ECMO availability? Owen and Alistair, I'll come to you in that order.
Right, thanks for that. So I think it depends on how sick the child is. So what we're doing in this second wave is we're managing many more patients in their local hospital together with the local paediatricians and supporting them as much as possible by teleconference. So no, I don't think all children need to be managed in a tertiary university children's hospital, but definitely I think anyone who needs well, obviously, anyone who needs intensive care needs to come to a paediatric intensive care unit, ideally one with multidisciplinary support with cardiology, neurology, rheumatology, and PIID on site. But there are a whole group of children who I think can be managed differently, who don't need those services immediately. They may need to come in, and we run a rapid access clinic daily for children from DGHs who need to come in for specialist echo, for example, but they just come in as a day and then they go back. So I think there's a mix and different people do it differently.
Thank you. Anything to add from north of the river?
I would agree with that approach, and I think we're going to learn more in this wave compared to last wave. In the first wave, we had 1 or 2 patients that required ECMO, which made us move to having not overcautious, but appropriately cautious approach to try and redirect patients that maybe weren't quite as sick to ECMO centres. But as we learn in this wave, that might not happen so often. We can draw back on that perhaps overly cautious approach.
Okay, so another quick fire question, I hope. Does BMI play a role in the risk of PIMS TS? Nick, you're smiling. Hermione, you're also smiling.
Yeah, nicely spotted. I would love to have an answer to that. I think that's really unfair. I don't know. I mean, some of the data has been presented earlier suggests there's a relationship, but
yeah, no, I think I would agree. I mean, it's so hard to know. We see it more in children from certain racial groups, in children who are older, in children who there's a higher proportion with a higher BMI, but you know, we don't really know how, you know, what that is in terms of the proportion of children who've been infected with the coronavirus. You know, we don't have enough of the epidemiology yet.
can I just add a word of caution is that obviously exercise rates have greatly fallen off. And as a rheumatologist, I'm really interested in kids keeping physically active, you know, so we have to be absolutely certain about the message we give, because what we don't want is for those who are with a high BMI then shielding more when actually we want them outside for an hour and a half each day.
I think that's an amazing point. Thank you. Right, what was the next question I was going to come to? Ah, yes, Philip. Is the mitral valve regurgitation described due to LV load dilatation rather than valve pathology itself?
So I think surprisingly, in the cohort of patients we have had so far, the LV was not really dilated, which was quite a surprise for us. So in vast majority of patients, the LV dimensions were basically normal, within the normal range, which again supports the hypothesis of myocardial stunning. So I don't think this is, I think this could be related to cardiac dysfunction. There may be some mild left ventricular dilatation, but I don't think this was really related to any sort of cross dilatation of the left ventricle.
Thank you. We are coming towards the end of our session, so we'll just sneak in another couple of questions. We haven't heard anything about remdesivir today. Is that not something we're using in paediatrics? Alistair.
So the remdesivir is being studied and used for acute COVID, for pulmonary COVID with active sort of viral multiplication going on, and as this is seen, PIMS, TS is thought to be a post-viral phenomenon, then the utility of an antiviral agent is considered to be probably relatively limited. The evidence for its efficacy from adult studies in acute COVID is quite limited as well, and there's a very narrow current indication for its use nationally in its commissioning and licensed indication. We have used it occasionally in children according to that licensed indication in GOSH with acute COVID, and we will very occasionally still use it on compassionate access program, but we've not used it for PIMS TS.
Thank you. And then just a very practical question. A patient with very late onset PIMS TS with a history of COVID but no current positive PCR, what is your infection prevention control plan for this patient in this situation? Who would like to take that one? Alistair.
I think you can ask me, and then you can ask Hermione, and then you can ask other people, and everyone's doing something slightly different. But we have an excellent lead for infection control, Helen Dunn, who I defer to for all of these questions as my guru. We have a very cautious approach at GOSH, which some people might say is slightly overcautious. But we have, just as a cautionary note, we have seen some patients that have barn door PIMS TS, that are PCR negative, that have become PCR positive next day, 2 days later, 3 days into treatment. And so I think for that reason, we are very cautious in terms of our infection control procedures and have very clear sort of step downs and instructions on when we're clear to step down those precautions. But I think St Mary's do something slightly different, so Hermione might want to comment.
Well, not necessarily. I think we try to be cautious too, but I would also highlight that it's not just the child, it's also the parent as well. And so you need to know, that the parent is asymptomatic, and ideally the parent should be tested too. But I think when you've got children who are recovering, and by that time you know that they're PCR negative, actually I don't think that they, some people have the luxury of lots of cubicles, others do not. So it's reasonable to think about recovering children being cohorted in a bay, and indeed that might actually be quite nice for them to be with other kids and get a bit more stimulation. So we're thinking about putting the recovering children in together.
And those from the Evelina group, Owen, Marilyn, Nick, anything different to say or similar approach?
No, I was just going to, I'm glad that Alistair and Hermione raised that, because we're seeing some cases as well who are COVID positive or are becoming COVID positive. And we weren't seeing that in the first wave. So I think this is a very interesting phenomenon. But I think, just like you, we just defer to infection, IPC, CNS, and do as we're told, quite frankly. But I guess we're pretty cautious. I think Marilyn might be able to talk. And also they've got these lovely tents down in ICU. What are they called?
Yes, exactly. We are looking after patients in tents in terms of infection control. So even in the first wave, we were quite cautious, although I agree with Owen, I don't think we had any PCR positive children in the first wave. So they had antibodies, but not antigen positive. However, in this wave, we are seeing some that are positive. So our approach is pretty cautious. They all get isolated until we have 2 negative PCRs. And yes, we're having to use tents to do that.
And thank you. I'm just going to wind up with one last question. As we've progressed through this afternoon, also we've all got a little bit older. Are you seeing PIMS in young adults? Owen.
So, yeah, I've been working with the adult team at St Thomas's. So in our MDT today, so we're seeing that crossover. We're seeing the 17, 18-year-olds. So are they young adults or are they older children? Who knows? But certainly in our MDT today, there was an 18-year-old on the adult ward with clear-cut PIMS, no question about it. And they're joining our paediatric PIMS MDT for management advice. But the adult people have a series of 25 to 30-year-olds with clearly PIMS, which some of them were missed in the first wave. They were thought to be COVID myocarditis, all sorts of things, but I think in retrospect are PIMS. So we saw it last year. We're seeing some this year. I don't think there's any difference. I think the continuum of of 18 to 25-year-olds is a continuum of the teenagers and young children we're seeing. I don't think they're different. I don't think they're a different species of human. I think they're just older children. So I think it's not surprising we're seeing 20-year-olds with it.
Thanks, Owen. Philip, anything to add from your experience?
So I don't really deal with patients over the age of 18, so I can't really comment on that. But for the previous question, we had one case where the admission sample was basically split, one for the rapid PCR and one for the in-house PCR. So basically the exactly same sample, two different tests, and one was positive and the other one was negative. So I think we also have to bear in mind that there are some limitations for testing.
Thank you to the whole panel. It's 6 o'clock. I'm going to turn into a pumpkin. Harriet's going to wind it up.
Thank you, Lucy. I've just got one slide I'd like to share, which has got a couple of thank yous on, and I can't find all my windows. A couple of thank yous on and some contact email addresses for everybody. So thank you so much to everybody for attending. We hope you found it useful and informative. I've put our email addresses up on the screen there. I hope you can see that and that my little box isn't in the way. I've put the email addresses for the South Thames Paediatric Network, the Guy's and St Thomas's Evelina London CHD Network, the North Thames Paediatric Network and the One Heart CHD Network. So please do get in touch with us. We've had lots and lots of requests for recordings from today. It takes about 12 hours for Zoom to download recordings onto our devices. So we'll do that overnight, get the link sorted tomorrow and send it on to everybody whose contact details we've got. And then please do share that more widely. Thank you so much to all of the speakers. Your contributions have been so valuable, and particularly thanks for staying on to take part in the panel. And then I'd just like to say a final thank you to Adrienne Cottam and Teresa Davey, who did a huge amount of coordination and hard work in getting the day together. So thank you to both of them. And we'll see you again soon. I'm sure we'll be running more webinars, potentially, as just mentioned, on long COVID and other areas. So thanks again and see you again. Bye.